Please start me. We are live.
Namaskar and good evening, everyone. I welcome you all for the webinar on emerging treatment approaches for NSCLC and head and neck cancer. With immense pleasure, I would like to invite Dr. Naresh Somani, who is Director Oncology and HOD Medical Oncology at HCG Cancer Center, Somani Hospital, Jaipur, for the welcome and introductory note. Over to you, sir.
Thank you, Team Horizon, and good evening, everyone. First of all, let me thank Dr. Tarachand Gupta for so many things that, in spite of being in the busy practice, he remains on the forefront of the academic activity. So many webinars in the physical meeting, I am witnessing that he is doing. He is doing it regularly, so that's commendable. That's one should be appreciating it. And this 2 days webinar on the common topics of the lung cancer and the head neck cancer is, I think, one of those series which he is conducting, and I wish that he will be continuing conducting. Now, if look at the program of the day one, that is the lung cancer. So it includes so many interesting things like emerging biomarkers, rare mutations. I am of opinion that these rare markers are no more uncommon or rare markers in the era of the NGS, which may be the limited platform or dedicated platform for the individual malignancy like lung cancer, or maybe a comprehensive genomic profile. More and more these mutations, uncommon, infrequent, or the common mutations or double mutations, we will keep seeing, and it will always be challenging and interesting that how we manage them in the first line or subsequently at the time of the resistance or the progression, which may be the local oligoprogression or the distant mets, something like the brain metastasis. Now, stage 3 disease, whenever we used to talk so far, we either dissect these patients in the two groups, either chemotherapy followed by attempt to surgery or chemoradiotherapy, that's all. Now, in the era of the immunotherapy and in the era of the biomarker-based treatment, the stage 3 has become a very hot topic in the lung cancer. You can attempt neoadjuvant chemo plus minus IO in select operable resectable patients, followed by surgery plus minus RT, or upfront surgery followed by in R0 resection positive, R0 resected patient with the PD-L1 positive, something like immunotherapy Tecentriq, or CTRT followed by consolidation immunotherapy, or patients post-surgery EGFR positive, something like osimertinib. So stage 3 has again come in the central stage, and we often talk of the stage 3 disease, something like which we commonly talk about the stage 4 advanced lung cancer, which we often talk, something like EGFR positive patient, what's the new, how to deal them the first line, how to deal them in the, at the time of the progression, what is the value of the repeat biopsy, repeat NGS test, how to deal the or identify the resistance, and so many things. If we look at the today's speakers and the faculties, yes, carefully selected faculties are there with us, like Dr. Charu Behel from the Bangalore. She will be talking about the biomarkers. Dr. Elam Darlan, one of the emerging fine surgeons in the field of the thoracic oncology from the Rajiv Gandhi, is there as for the panel discussion. We have the Dr. Tanvi Sood, medical oncologist, for the stage 3 discussion, and Dr. Rohit Ribello from the Udaipur is there for the ALK positive patient, and Dr. Akhil Kapoor, a well-known figure in the field of the medical oncology from the TMH Varanasi, will be discussing about the uncommon mutations. And then again, we will be having the first line ALK positive patient, how to deal them. Always there is a debate as on today, like alectinib versus lorlatinib, and how to deal these patients if we start upfront with the lorlatinib, and so on. And Dr. Vikas Talreja, Dr. Rajit Chanana is there for the management of the EGFR positive patients. And Dr. Vikas Talreja is there for the uncommon mutation like MET exon, skip mutation or amplification. And then concluding remarks will be given by our organizing person, Dr. Tarachand Gupta. So with this, I would like to request to start with the first session, that is about the what's new, what's the standard of care regarding the biomarkers in the actionable uncommon mutation in the NSCLC. Over to organizing team. Thank you. Back to organizing team, please.
Thanks, Somani sir, for nicely highlighting the webinar's topics and your special remarks about the progression in the oncology field in the common cancers. Now, today we are going to discuss a whole day with the lung cancer NSCLC. And as we know that the lung cancer talk cannot be completed or should not be started without talking about the biomarkers, because of which now the lung cancer treatment is flying and it has changed the paradigm of complete paradigm of the treatment. So now I invite Dr. Charu Bahl from Bangalore, Manager Scientific Committee of MadGenome Labs, for the talk on new biomarkers and targetable uncommon mutations in non-small cell lung cancer. Dr. Charu Bahl, over to you.
Yeah. Thank you, Dr. Tarachand and Dr. Naresh Somani, for giving us this great opportunity to talk about some rarely found mutations, and definitely the mutations which are, difficult to understand and also but greatly affect the treatment sometimes. So I will be just taking you through the biomarkers and certain important upcoming recent advancements in uncommon mutations, and what are the probable therapies that are coming up for these mutations and kind of impact they have on the treatment outcome. So as you know, as we have already stated, non-small cell lung cancer is a kind of cancer where you have a proper workflow where there are multiple options available, but definitely NGS platform is one thing which has to be done in terms of getting the clear picture about the tumor and selecting the right therapy for the right patient. So there is intermediate option of doing PD-L1 testing along with a complete NGS panel, which includes EGFR, AL-cross, RET, NTRK, BRAF, HER2, MET, exon 14 skipping mutation in a single go. Or the option second is you do single gene PCR analysis if the patient cannot afford it, or there is a tissue you can say tissue is limited. So in all these situations you can definitely understand, either you go for single PCR based assays or you go for a complete NGS panel. And now there is a third option where you can directly go for a liquid biopsy as well if there is a constraint on doing a biopsy or getting the good amount of tissue to run all the genes in a single go. So if we look at the frequency of oncogenic drivers, EGFR is one of the most commonly found mutation, which is occurring mostly at the rate of more than 30%. If you look at Asian population, it is far more than 30%, as well as we see in our own internal data as well. So there are two important categories for EGFR. One is common mutation and other is certainly uncommon mutations. These are all categorized as per their location, which I will be talking in the coming slides. EGFR exon 19 deletion, 21 mutations, and EGFR exon 20 insertions definitely are categorized in a separate category because they do not respond to the usual TKI inhibitors which are used for other common EGFR mutations. So they require a subsequent therapy of avutometinib or mobocertinib, and that's why splicing out the mutations, just the positive and negative, is not the answer anymore. To actually understand the mutation, where it is located, what impact it is having, and which therapy works for it is the end-to-end solution for each and every patient nowadays. So if you look at the molecular testing guidelines by none other than NCCN, it also signifies that if there is insufficient tissue to allow testing for EGFR, KRAS, AL-cross1, and repeat biopsy or a plasma testing should be done. So plasma testing is also coming up as a frontline in those cases where the tissue is not available. And these are, if these are not feasible, then treatment is guided by results unavailable, or if unknown, these patients are treated as if they do not have any driver oncogenes. So this is what the principles of pathologic review in the NCCN guidelines recommend. And rest of all the genes, as mentioned here, they are to be tested in the front line as a broad molecular, as a part of a broad molecular profiling. That is how we can actually get all the uncommon and common mutations in one go. So if you look at the principles of molecular biomarker analysis in non-small cell lung cancer by NCCN, it recommends a broad panel-based testing, typically performed by NGS, and also it helps you to understand that in broad panel testing, if you don't have any identified driver biomarkers, specifically in never smokers, you should consider RNA-based NGS because it maximizes the rate of detection of fusion events. So definitely when you are selecting a panel, you should see whether you are doing the fusions, that is the rearrangements, by RNA-based NGS or DNA-based NGS. If it is DNA-based NGS in a non-smoker and it is coming negative, you should consider RNA-based NGS because there will be some mutations, some fusion events that occur in the deep intronic areas which are not sequenced in the DNA-based NGS, because generally the probes do not cover the DNA-based, the deep intronic regions. That's why RNA-based NGS is the wholesale best, you can say it is best technique to maximize the detection of all known and unknown partners for fusion events. So that's what my next slide also focuses on, that RNA-based NGS is the optimal method to detect gene fusions. This is why I am highlighting this is because if we are not doing RNA-based NGS, we might miss some of the uncommon fusions that could be present. And we have had cases, at our lab where earlier DNA-based NGS was done at a FDA-approved lab, and further patient was found to have a ROS1 fusion, which was detected because of the RNA-based NGS. So definitely RNA-based NGS identifies actively transcribed fusions and it avoids tiling through the intronic regions. That's why it is the optimal method for detecting all gene fusions, barring IHC, FISH, RT-PCR, or DNA-based NGS. Now, if we come to EGFR particularly, so EGFR basically has 2-3 different types of mutations. First is EGFR activating mutations, which activate the EGFR gene. There are exon 19, exon 21, and other uncommon mutations which are not commonly found. And there will be exon 20 insertions as well. Some T790M, C797S, which are secondary site mutations, and T790M is primary resistance mutation. Typically, T790M and C797S are osimertinib resistance. So, targeted PCR approach based might lead to under detection of exon 20 insertion events. That's why NGS is preferred, because exon 20 insertion rate is also almost we have seen in 5 to 7% patients having exon 20 insertions. So if you are doing a targeted PCR approach, it might lead to missing of the detection of exon 20 insertions. So if you look at uncommon EGFR mutations, this is just a very elucidated diagram which shows you exon 18, 19, 20, and 21. So the mutations which are uncommon here are some have some sensitivity to EGFR TKI, something like G779X, which is in exon 18, and L861Q, which is in exon 21. So these mutations have some sensitivity towards EGFR TKI, and others like you can say, I mean, in terms of T790M and S768I, these are all mutations which are related to EGFR TKI resistance, which are there in exon 20. And exon 19 generally have mutations which are mostly TKI sensitive, which are generally deletions. And if you look at secondary mutation like T790M, it basically is a resistance mutation. So it is a secondary mutation, means it occurs after the patient is treated. Sometimes it is acquired after the treatment of the patient with some TKI in the long run. So for patients who have non-classical EGFR mutations, it is seen that afatinib shows better outcomes in terms of PFS if you compare it with the first generation EGFR TKIs like gefitinib or erlotinib. Similarly, osimertinib has been shown to have a favorable activity with manageable toxicity in patients having recurrent uncommon EGFR mutations with a median PFS of 8.2 months. So this is some data which I have got from after just looking around few publications. I hope I'm very clear on the uncommon mutations, which where they are located and what is the strategy to identify them. Next, we come to another important topic of compound mutations. So in EGFR mutation landscape, where we have exon 19, exon 21 point mutation and exon 20 insertion, there is a category of uncommon mutations where you have a category where there are compound mutations, and in 4 to 26% of the patients, they might have compound mutations, which means they have more than one mutation. So it could be a combination of two common mutations, sorry, one common and one uncommon, or both could be uncommon, and there could be any mutation along with de novo T790M. So de novo T790M is basically when you find T790M at the time of diagnosis. So that is also uncommon mutation because that patient will not even respond to osimertinib. Now coming to type of mutations you see in ALK rearrangements. Generally, ALK EML4 rearrangement is classified as one category, but I would just like to highlight this, that there are three types of breakpoints in the ALK EML4 fusion proteins. They are called V1, V2, and V3. So they are basically formed because of the fusion of different exons with the ALK region of EML4, exon 13, exon 20, and exon 6. So exon 13, that is V1, it is the most common one. And then there is V2, and then there is V3, which is 30%. So V3 is one which is basically categorized as high risk feature for the ALK positive patients, and they do not have that good response to the first line ALK inhibitors, and they also have a tendency to show early metastatic spread, treatment failure after TKIs, and the chemotherapy and cerebral radiotherapy, and they have inferior OS. So basically this this categorization of the mutation of ALK EML4 fusion helps you to predict status for your ALK positive patient, which is, I think, really interesting in terms of having a better prognostication, selecting the higher generation ALK inhibitor for these kind of patients. Now coming to ALK resistance mutations, there are several mechanisms because of which we see ALK resistance in patients. So one of the commonest mutation is, which is mentioned even in NCCN, is G1202R, which is the most common secondary resistance ALK mutation, which is found in post-treatment patients, even with second generation ALK inhibitors. So in these cases, lorlatinib is having strong activity for all these mutations, and it works well for this. So when we are actually doing ALK sequence, I mean, we are repeating the testing for ALK patients once they start showing progression. So we need to sequence the ALK gene, not look into the rearrangement. So we should see that all the exons of the ALK gene are covered in that particular NGS test which we are selecting for the patient, so that we can capture all the resistance mutations. Similarly, if we look at MET gene alterations, so in MET gene alterations, there are 3 different things that can happen, which are MET fusions, which are generally, MET amplification or MET mutation like exon 14 skipping mutation. These are 3 types of events that can happen in the MET gene, and MET exon skipping mutation is more common. However, MET amplification is not that common, but it is found as one of the mechanism of EGFR TKI resistance that I will just discuss when I discuss the resistance for all together. And if you look at exon 14 skipping mutations, they occur in both smoker and non-smoker, and they can so they should be actually captured by RNA-based sequencing. So we at MedGenome are doing the MET exon 14 skipping mutation by RNA sequencing, because there is a whole exon deletion that happens from the intron exon boundaries, and when we do it by RNA, we can very well configure, because all the introns are gone and we are looking at the transcribed sequence of the RNA, of the mRNA for MET protein. So that's why we can very well see that gap of the exon deletion which is there, and we can be very sure about the exon 14 skipping mutation, and we never will have to miss it, even if the splice site is a little bit here or there in terms of the site of the mutation. So MET amplification, as I discussed, is a EGFR TKI resistance mechanism, more of it, and it is attributed to 5 to 20% in the patients who are treated with first generation TKI, and might be as high as 25% in those who progress on third generation EGFR TKI. So 25% patients who are progressing on third generation EGFR TKI might have a MET amplification. So this is a very common mechanism, and we have also seen coming up the MET amplification cases, as now we are doing more and more repeat cases for EGFR treated patients. Similarly, for KRAS, it is an upcoming marker. As you know, KRAS is one of the commonest mutation we see in the lung cancer cases, but there was no drug earlier, but now we have sotorasib, which can be given in the patient who are at least, previously received one or other systemic therapy treatment, such as chemotherapy, and have the KRAS mutation G12C. Along with the KRAS being a poor prognostic marker occurring more in light or non-smokers, and also having a relation with good response to immune checkpoint inhibitors. It is also showing that if there is STK11 mutations, they are associated with poor prognosis in KRAS G12C mutant non-small cell cancer patients who are treated with first line immune checkpoint inhibitors. So coexistence of these two mutations is important to see, whether only one mutation is there or there is STK11 along with KRAS. So accordingly, you can decide whether you should start the patient on first line immune checkpoint inhibitor or not, along with the PDL1 data, which you will be doing with IHC. So now, just to understand in a very broad manner about the targeted therapy resistance, which we see majorly in the lung cancer patients, because there is a lot of, targeted treatment coming up. So hence, there is a lot of development on the therapy resistance mechanism also. So if you look at it, it is divided into two important categories: on target resistance, off target resistance. So on target is basically whichever gene we are targeting, there is a gatekeeper mutation that happens in that gene specifically, like EGFR T790M, RET V80, 4M or ALK mutation, or then is a solvent front mutation. So there is a mutation on the other front. There could be compound mutations which could be there, and then there could be off-target mutations like abnormal signaling by MET amplification or FGFR amplification, and there could be downstream signaling pathway abnormalities, like there could be MAC pathway or PIK3CA pathway. Like we say that if there is a KRAS mutation and EGFR mutation which can be targeted, so in the same patient, then the poor response will be there to the EGFR therapy, because it is a downstream signaling abnormality that will not let the EGFR inhibitor make the pathway stop. So KRAS will keep on proliferating, making the pathway go in upstream setting. So the therapies which are indicated for these, for example, the combination of first and third generation EGFR TKI could overcome the resistance of EGFR 19 exon 19 deletion with T790M in trans with C797S. So if there is in the same in the different clones, that means the mutation is coming from two different cells, that is T790M and C79S. They are not in the same cell, that is the same clone. Then a combination of first and third generation EGFR TKI could help benefit the overcome the resistance of this. Another cause of EGFR TKI resistance is bypassing of the signal, as I just discussed, MET amplification, RET rearrangement, anti-RK rearrangement, or even a BRAF rearrangement, which we have seen in one case, which was very unusual. We found a BRAF fusion, and abnormalities in downstream signaling such as KRAS and PIK3CA, as I just discussed. So more or less, these are the uncommon and the pathways of drug resistance mechanisms, which, you know, these are the ones which are coming up these days. And then the resistance mechanisms for approved targeted therapies, as I just discussed. So for each and every gene, there is a resistance mutation that is commonly reported. And most of this I have already discussed. So there are methods to overcome these resistance. Either you try a combinatorial therapy, or you go for a sequential therapy, or there is a combination of chemotherapy and EGFR inhibitor in case of red gene. So there are different combinations of drugs which you can try and overcome the resistance with. So that's why it's important to understand the drug resistance mechanism, and for that I think broad spectrum testing is very important. Now, some of the upcoming fusions or targets that are coming in non-small cell lung cancer, something like NRG fusion, DDR mutation, P10 mutation, STK11 rearrangement. These are all new upcoming targets in NSCLC, and there are clinical drugs, agents that are, some are on the market, some are on the clinical trial side. If you look at NRG, there is afitinib also, which can be used, but this is all on the off-label side. There are no current approvals for it. Similarly, KRAS, we have sotorasib, and so there are various drugs that I think in the coming year or so, we will have on board for these emerging targets in non-small cell cancer, where we see more mutations that could be targeted, and there could be better outcomes. Then liquid biopsy, as I just discussed, the complementary or a sequential approach is coming up. Also, in cases where tissue is unavailable, plasma first approach is important. So we see a lot of variabilities in the results when we are doing liquid biopsy testings for already treated patients who had baseline mutations during the time of diagnosis. So it is important to understand at what step of patient's progression or treatment journey we are doing this testing. Sometimes there could be oligometastatic condition, and in those conditions, the cfDNA will not have that kind of tumor cell load in the plasma, and we are not able to detect those mutations in case of oligometastasis. In case of CNS mets also, there is a limitation for such a condition, but there is a lot of other benefits also. If you look at it, you can monitor the patient's progression, and you can screen for patient specific alteration. You can also have complementary testing where you can overcome the view of tumor heterogeneity, and that's how this can really help. Now, this is two cases I just want to present. So this is the detection of EGFR exon T790M, which we found in the liquid biopsy for this patient. We also found the exon 19 deletion, and at a very good depth, we found the exon T790M mutation. So this was after the patient was treated with TKI therapy. Similarly, this is a case where patient was ROS1 fusion positive in 90% of the cells, and when we did a OncoTrack Advance, which covers SNVs, indels, and fusions, and we found a ROS1 fusion and also a known resistance mutation of G232R in the ROS1 gene, and because of which ROS1 resistance was found, and definitely patient is now have to be changed. Patient changed the treatment for which the ROS1 inhibitor was not working anymore. So the current scenario is that with an increasing number of genes to be assessed and comprehensive profiling coming up either using tumor tissue or plasma, it is becoming a more efficient method at the time of initial assessment, optimizing the turnaround time for the results and using the tissues samples for other analysis. So that's the major barriers which we need to overcome and understand the importance of more and more progressive testing in case of non-small cell lung cancer. So that is it from my side.
Thank you, ma'am.
Yeah.
Thank you for the excellent talk. And next, I would like to invite Dr. Tanvi Sood, who is a medical oncologist, and for a talk on translating evidence into practice in stage 3 non-small cell lung cancer. Over to you, ma'am.
Hello, thank you. So I'm just going to try and share the screen. Or is the organizer going to share it?
Ma'am, any which ways you want us to share, we will.
Let me just try this. Is it visible?
Yes, ma'am. Just make it full screen.
Oh.
Yeah.
Is it full screen
Fine.
now?
Yes,
Great.
ma'am.
All right, okay. So thank you. At the outset, I'd like to thank all the organizers for having me here, and thank you AstraZeneca for the slide set. We'll be talking about translating evidence into practice in stage 3 non-small cell lung cancers. So why is this topic, still very relevant? Because we know that the lung cancer in India is progressively increasing. The cancer incidence is about 70,000 per year. The cancer-related deaths that are due to lung cancer is around 66,000. And we know that even amongst males especially, lung cancer is still the number 2 most common cause of cancer. So the disease burden is especially a very important reason. Second of all, the management of unresectable stage 3 NSCLC. So even in this, we know that it's always a multidisciplinary tumor board that takes into place whenever we are addressing stage 3 patients, especially unresectable. So radiation oncologists, medical oncologists, pulmonologists, thoracic surgeons, pathologists, nuclear medicine, everybody sits together and tries to understand what would be the best treatment approach. After a diagnostic and pre-treatment evaluation, all patients go through pulmonary function testing, bronchoscopy, FDG PET-CT scan, establish the staging, get a pathological mediastinal lymph node evaluation, and to complete the staging, we always get brain MRI with contrast. Most of these patients do end up getting the standard of care, which is concurrent chemoradiation. So definitive chemoradiation is the standard of care for the longest time. And enough trials have demonstrated that concurrent chemoradiation is indeed superior in outcomes when it comes to sequential chemoradiation. So these are the regimens that have been tested out concurrently with chemotherapy. There has been cisplatin etoposide combination, cisplatin vinblastine, cisplatin pemetrexed, paclitaxel, which is used most often in practice, and the weekly regimen, then cisplatin etoposide. And amongst this, we know that the most practically relevant ones with the great median OS survival outcomes was the cisplatin pemetrexed or the paclitaxel, with lesser toxicity also as compared to cis-pemetrexed. So that is the standard of care, although this does depend on the performance status of the patients. If the patient is fit and able to take concurrent chemotherapy, that's what we like to go ahead with. But if for any reason patient is very frail, not fit for a combination therapy, then we like to still go for a sequential regimen, which has shown a modest median OS of around 14 months. So we know that there is a large unmet need in stage 3 NSCLC. Why? Because we try to treat our patients with a curative intent, but this does not translate so. About 40% local regional recurrences are seen and 50% distant metastases are seen. The median PFS is quite modest, just about a year, mostly in most patients lesser than a year. And 5-year OS is still abysmal, 15 to 25%, which is not even as high as stage 4 patients with driver mutations. So definitely this area has a huge gap and there was a lot of work required here. Now, different types of strategies have been tested out, like consolidation therapies have been tested out. So these are the various trials that has been shown in this table, where it was tried to show that if any kind of consolidation therapy after concurrent chemo-RT translates into any sort of benefit, whether it is further chemotherapy regimens or whether if it is a TKI. The SWAB trial also was irrespective of EGFR mutation, but here it was seen whether a gefitinib consolidation is of any use. And what all these phase 3 studies have shown is that the consolidation with chemo or targeted therapy did not actually end up showing any PFS survival benefit or OS benefit in these subset of patients. So we know that the evolution of treatment approaches for unresectable stage 3 NSCLC, it started with radiation alone, then we progressed to sequential CTRT, then we progressed to concurrent CTRT, and then there was a trial to establish that CTRT concurrently given is actually superior to sequential CTRT. And we've just about been stuck over there. No amount of induction chemotherapy or consolidation chemotherapy has translated in any kind of OS benefit. So these trials largely tell us that more chemotherapy is not the answer. So concurrent RT has remained the standard therapy for patients with good performance status, while sequential CTRT, as we discussed earlier, patients with marginal performance status can be given this option. Although all these still translate into about just 15% survival at 5-year. To improve prognosis, further strategies like increasing the radiation doses or induction chemo, consolidation chemo, everything has been evaluated, but we have not really come across any significant OS benefit with such strategies. So that leaves us with immunotherapy, and immunotherapy came as a great tool in consolidation space. And this was all based on the Pacific trial. So this was the phase 3 RCT double-blind placebo-controlled multi-center international study. Here we know that the patients with stage 3 locally advanced unresectable NSCLC who have not progressed on the definitive platinum-based CCRT, so both carboplatin and cisplatin was accounted for. And these are the patients who don't have progression post-concurrent chemo-RT, patients whose performance status was either 0 or 1, and archival tissue was also collected. All comer population were tested. And the durvalumab, which was given in 10 mg per kg, this was in the study group. This was given every 2 weekly for up to 1 year. And this was compared to placebo, which was also given in the same dosage for around the same duration also. So durvalumab was started 1 to 42 days post-concurrent chemotherapy. And during this duration, it's imperative that there is no sign of progression post the concurrent chemo-RT. The primary endpoint was PFS and OS, and the secondary endpoints were overall response rate, duration of response, safety, and tolerability. and patient-reported outcomes. So overall, the patient baseline characteristics were well balanced across the two groups. We can see that the disease stage 3A were around 52% in both, and 3B were around 44%. And EGFR mutation was also accounted for. So here there was only 6% positivity rate in this subset of patients, and 66% were not positive. Unknown category was around 27%. We can also see the PD-L1 expression stratification, because the dictum says higher the PD-L1, the immunotherapy is expected to have better results. So the stratification was done on PD-L1 expression, TC less than 25% or TC equal to or more than 25%. So we can see that about 40% patients had TC less than 25% and another 25% had TC more than 25%. Amongst histology also, squamous were around 47% and non-squamous were 52%. And we can see that the fair share of patients were former smokers, about 75%. Most of these patients had got concurrent chemoradiation, about 99% patients, of which 25% patients also had got induction chemotherapy for initial debulking, which we do practically do in our practice. And if we see what was the best response post-concurrent chemotherapy, as expected, most patients had responses in the form of partial response or stable response, about 50% in each, and hardly any complete response post the concurrent chemoradiation evaluation. So the prior CRT at baseline, all patients received 2 or more overlapping cycles of platinum-based chemotherapy concurrent with RT, and patients may have received prior chemotherapy also, as we have already discussed. This is the updated 5-year survival data in the intention to treat population, and we can see the curves start separating right from the first month itself, and we have a very good separation as it goes further. At 5-year updated analysis also, the median OS is about 47.5 months as compared to 29 months in placebo group. So this is a remarkable achievement in the unresectable stage 3 lung cancer subset, where we are able to see for the first time a great median OS survival, and this is going to the tune of almost 4 years. And we can see the curve separating very well. At 5 years, it is 42% versus 33% overall survival rates. So this is the first and only approved IO to demonstrate such a remarkable 42% OS rates at 5 years. This is the updated PFS, where we can see that the curves start separating, and at 5-year update, we can see 33% patients, 33% PFS rates and 19% PFS rate in the placebo group, where the median overall, where the median PFS is around 16.9 months as compared to 5.6 in the placebo arm. Hazards of 0.55. So again, a sustainable, durable PFS of 33% at 5 years, which is far much better with chemotherapy, concurrent chemotherapy with radiation alone. Now, when we look at the subset analysis also, all subgroups, they seem to have a good benefit with durvalumab consolidation. Barring the EGFR mutation status positive patients, in which there was a trend towards better outcomes when durvalumab is not utilized, that we'll talk about more a little later. But all subgroups by and large showed that there is a good survival benefit when durvalumab consolidation is given, regardless of PD-L1 mutation, regardless of the best response prior to treatment, and also regardless of the histology of the lung cancer. And in all these patients, even when it comes to PFS also, we can see that all subgroups have shown a very good benefit. So the first subsequent therapy after discontinuation of durvalumab, this 41% of patients in durvalumab arm and 54% patients in the placebo arm received a subsequent disease-related anti-cancer therapy. And systemic therapies, whether administered with or without radiation therapy, were the most common for subsequent anti-cancer treatments in both durvalumab as well as the placebo arm. So in the form of subsequent therapies, there could be platinum doublet chemotherapy or single agent chemotherapies. Further, immunotherapy was also tried, targeted therapy in some subset of patients, radiation alone. So the patterns of the disease relapse at progression, reduced rates of first progression were seen in the durvalumab arm, which was around 45% as compared to 64% in the placebo group. And the intrathoracic progression was the most common when it came to durvalumab arm. So this also kind of guides us that the systemic relapses, which is the usual problem, was much lesser in these subset of patients versus 74% in the placebo group. So patterns of disease progression, what was the time to intrathoracic progression only or death per BICR? Durvalumab improved the time to intrathoracic progression also when it was compared to placebos. When the durvalumab, it was about 2 years median time, and in the placebo group, it was as low as 10 months, and the hazards were 0.5, very significant difference between the two. So coming to the safety summary also, when we look at the grade 3, 4, any grade toxicities, durvalumab was well tolerated, and we can see that leading to discontinuation, it was about 15% in durvalumab as compared to 10% in placebo. And the serious adverse events also were about 30% in durvalumab and 23% in placebo. So the safety summary overall also, we know that pneumonitis is something that we are worried about, especially in these post-radiation kind of patients. And here we can see that the grade 3-4 level toxicity was about 4% in less than 14 days. And after 14 days, it was about 3.4% in the study arm with durvalumab, which was compared to the placebo arm of about 1 to 3%. So again, the serious side effects were about 30% in durvalumab arm and 33% in the placebo arm. So when we talk about translating it into real world practice, this is what we want to highlight. What is the real world scenario? Because most of our patients don't actually come in PS0 or 1. So we would like to know how this data translates in the real world. Now this is the data from Nicholas Girard et al., where the study design was similar. This is an ongoing observational retrospective study. So here the patient population was unresectable stage 3 NSCLC regardless of tumor PD-L1, no evidence of progression following platinum CRT. The index date of starting durvalumab was September 2017 till December 2018. So these are the patients that were taken in for 5-year observation to evaluate the disease evolution. And the endpoints were investigator assessed PFS and OS. So as of November 2021, the FAS had included around 1,000 patients across 10 countries. And the median follow-up duration in patients censored at the end of data extraction was 38.7 months. So majority of these patients were less than age of 75 years, and 15% patients had actually received sequential chemotherapy like we do prefer in patients who are not very fit for concurrent therapy. And most patients had stage 3B or 3C, around 53% patients. Most patients had non-squamous histology. And if we look at the TC presentation also, the PD-L1 expression here was stratified by TC more than 1%, which is around 72% of the included population. So more than 60% of patients were estimated to be alive at 3 years. And these OS outcomes were numerically better among patients who received durvalumab within 42 days of finishing the RT. So here again, we can see that at 3 years, there is around 63% OS survival rate. And at 2 years, it was 74%. So again, very similar outcomes we can see in the real world scenario also, where the median PFS has been reached, it is around 24 months, and more than 40% patients were estimated to be alive and free of progression even at 3 years. So similar data has been translated even in real world practice that immunotherapy consolidation post CCRT is indeed very beneficial in terms of both PFS and OS. So this is very encouraging outcomes that have been noticed in patients who have received sequential chemo-RT also. So the concurrent chemo-RT and sequential chemo-RT survival curves did not separate until later in the follow-up period. Now, these are the outcomes. These are the outcomes in PD-L1 subgroups from PACIFIC-R. They were numerically better than those observed in the PACIFIC trial. In the PD-L1 TC more than 1% group, the 3-year OS survival rates were 67% as compared to 61%. So this has been compared to the PACIFIC trial data. And in the PD-L1 TC less than 1%, the 3-year survival rate is 54% as compared to 47%. So outcomes from these real world studies and clinical trials should be compared with caution, of course, because there could be many differences in study design, but it does give us an outcome. Although we should not do cross trial comparison, it does give us an outlook on how the immunotherapy is being used in the real world and what are the outcomes that we are generally seeing. And even from the safety point of view, pneumonitis continues to be the main safety concern that we have to be aware of, and largely manageable, especially with corticosteroids. This is another study which has shown the real world outcomes versus the clinical trial results. And here this was tested out in veterans with stage 3 NSCLC by the Veteran Health Administration. And in the cohort 1, there was concurrent chemoradiotherapy and durvalumab. This was compared with concurrent chemoradiation alone. The primary outcomes were PFS and OS. Again, patients were about 68 years, and most of these patients were smokers. 41% had adenocarcinoma and 50% had squamous histology. The cohort 1 had higher rates of severe comorbidity as well. So here we again see a significant increase in both PFS and OS in this data also, where the PFS can be seen nicely separating very significantly, a very significant difference also. Median PFS was around 16.9 months as compared to 9.6 months. And when we see the median overall survival was about 34 months in these patients, not to forget that we have mentioned that there were comorbidities in these patients, which we generally see in the real world scenario also. All patients are not always fit. Many of these patients have COPD, heart conditions, and makes their fitness that much lesser for even enduring proper doses of chemo and radiation. So despite that, with durvalumab consolidation, there has been a very good survival difference and median OS of 34 months as compared to 19 months even in this data. To conclude, there is hope for cure in stage 3 NSCLC. We're not very far from that thought. Although this data set was done regardless of mutation status, now we are wiser. We know that there are studies looking into whether targeted therapy consolidation will change the way we look at these kind of patients. But as of now, the standard of care is chemo radiation followed by IO consolidation. More chemotherapy has not added any kind of benefit. If we are able to give benefit to our patients of immunotherapy, we're able to increase the survival outcomes, and actually survival at 5 years may become the more important endpoint, where there are around 33% patients that are still disease-free and alive at the 5-year mark as well. So the median OS of 47.5 months versus 29 months, hazards of 0.6 is truly remarkable, statistically significant, and clinically meaningful as well. And the OS and PFS improvement was demonstrated across all pre-specified subgroups. The 5-year OS was 43%, as we have discussed already. And these patients that were randomized to durvalumab, they remain alive at 5 years around versus 33% in the placebo group. So a third of patients remain both alive and free of disease, that is around 33% demonstrative OS benefit and a very clinically significant PFS benefit, which is unheard of in our unresectable stage 3 lung cancer patients. Definitely, this was a practice-changing data, and patients receiving durvalumab, they also have a lower incidence of new lesions. They have a lower incidence of brain mets also, and tolerability profile of durvalumab was acceptable. The favorable real-world OS and PFS results are also very encouraging, and they include both concurrent CTRT as well as sequential. So that actually relates more to what we practice in the real-world scenario. And this applies even to patients that are PD-L1 TC less than 1%. So even the FDA approval is regardless of the PD-L1 status, and these outcomes support the continued use of consolidation durvalumab after concurrent chemo-RT as a global standard for such patients. Thank you so much for your kind attention.
Thank you, Dr. Tanvi, for a nice talk on nicely elaborating the stage 3 lung cancer and post-CTRT maintenance, which has improved the survival also. And now just a question, Dr. Tanvi, if would you like to do any driver mutation test before starting durvalumab, or we will still continue durvalumab post-CTRT?
So as of now, I lightly touched upon it in my talk also. As of now, we definitely want to know what the driver mutation situation is. And there is a FLORA trial that is underway. We don't have the results as of now. Whatever retrospective data is there for targeted therapy consolidation has been very mixed. In fact, there is negative data also. But we have to keep in mind that those retrospective data, they didn't have EGFR mutation positive or negative stratification in those trials. And there is RECEL data also, which is a phase 2 trial data. It has also shown TKI with radiation, whether that translates into any sort of increased benefit. Especially these patients are known to fail systemically on immunotherapies. And there could be worse immune-related side effects also whenever patients are carrying EGFR mutations. So maybe we have to wait for the LAURA trial, that is the phase 3 trial that will be telling us if osimertinib consolidation post-concurrent CTRT is going to give us any survival benefit and what kind of survival benefit we are looking at. But till that data arrives in practice, we still practice immunotherapy consolidation post-chemo radiation.
And any stratification for PD-L1 receptor status?
So even for PD-L1 stratification, this data very beautifully elaborates that all patients actually end up benefiting regardless of PD-L1. Although, of course, we always know numerically that higher the positivity, better the outcomes are. But regardless of that, we know that that all patients, regardless of PD-L1, they do end up getting good benefit from immunotherapy consolidation. Just to demonstrate that, we know that FDA has given the approval regardless of the PD-L1 status, but the EMA actually endorses it should be PD-L1 more than 1%. So there is some data that says that more than 1% shows better outcomes. But at this point, we know that for these patients, we don't have any other good options. So whatever survival benefit we can get, and the subgroups analysis has also demonstrated that the PD-L1, regardless of PD-L1 status, these patients are doing well. So that's something that we also practice for all our patients.
Thank you, Dr. Tanvi. And the further questions we will take in the panel discussion. And to inform all the audience and the faculties that the panel which was on the managing early lung cancer cases discussion, which was supposed to be moderated by Dr. L.M. Darlam Delhi, he has to left because of some personal issues, and he cannot do this panel. So in place of Dr. L.M. Darlam, Dr. Vikas Talreja will moderate this session. And Dr. Vikas Talreja is a senior consultant medical oncology in Regency Hospital, Kanpur, and he will be moderating on the early lung cancer case-based discussion. And for this session, I invite the panelist, Dr. Rohit Swami. He is a senior consultant medical oncology in Narayana Hospital, Jaipur. Dr. Abhishek Jain, Ahmedabad. He is senior consultant breast and thoracic oncosurgeon, Shalvi Limited, Ahmedabad. Dr. Kamal Kishore Lakhira. He is an associate professor and my dear colleague, SMS Medical College, Jaipur. Good evening, all. Dr. Sonu Goyal, she is a senior consultant radiation oncologist, Apex Hospital, Jaipur, and myself also there. Dr. Vikas, you can continue.
Thank you, Dr. Tarachan sir, for a very kind introduction, and welcome all my panelists. It gives me immense pleasure, a beautiful agenda so far, and a very intellectual awakening talk so far. We have seen a lot of screening for our patients, and we are catching up disease quite early. And that's why early lung stage lung cancer has become so promising in our practice. So the first question I would like to ask Dr. Kamal, do you see quite often early lung cancer patients in your routine practice?
Yeah, it's not too common, sir. Like most of the cases which we see are usually like stage 3 onwards. But yes, on a random basis, like 1 or 2 odd cases per month, definitely we are getting.
And we have one more surgical oncologist, Dr. Abhishek, if I'm right.
Hi. Yeah. Good evening.
Very good evening. So, how common is lung cancer presenting in an early stage in India in your practice?
Right. So in not just in my practice, overall, if we see the scenario in our country, this is extremely rare scenario. just because the screening protocols are not very well established in our country, like many other countries. So yes, it is very rare to get a tumor, a GGO especially, and that is the reason why lung cancers were more increasingly detected during COVID times. But it is extremely rare.
So considering now the China has declared more than 1 million cases COVID in last 1 week. We have this gentleman with us, a 67-year-old non-smoker presenting with mild cough, chest X-ray showing small left upper lobe lesion, CT showing a lesion in the left apical lobe. Can I have the images next? Yes. So uh, how often is the reflex PET CT done at your place, Dr. Abhishek? And
Yeah.
what for?
So most likely, in most of the cases, whenever we see such lesions in a CT scan, my first step is always to get a biopsy done through a CT guided biopsy, and then we get a PET scan once the diagnosis of a malignancy is confirmed. So for me, the first step would be to get a lesion biopsy.
Wonderful.
And again, also, I always get a bronchoscopy done in all my lung cancer patients. So it's a routine for us. So, but this lesion doesn't look to be amenable to a bronchoscopic biopsy. So most likely, this patient will end up getting a CT guided biopsy
we
along with
agreed with
IFC.
we agreed with Dr. Abhishek, and we got a biopsy done. Next, what is the biopsy showing an adenocarcinoma?
Right.
And over to Dr. Santosh right now. Would you like to do any other further tests more, or you're happy with lung cancer early stage PET CT showing a localized lesion? Dr. Santosh?
Santosh ni Sonu, Dr. Sonu.
Sorry.
Dr.
We have
Sonu.
Dr. Sonu as the radiation oncologist, and
Yes.
surgical oncologist is Dr.
Abhishek and Dr. Kamal Kishore.
Dr. Kamal. So, Dr. Kamal, would you like to do any other further tests?
Yeah, definitely. Like the mediastinal lymph node staging has to be done, and see, if suppose on PET CT scan it is not showing the disease anywhere else, okay, then definitely either the EBUS or US guided FNCs, or if suppose, like I usually prefer to get, if possible, the EBUS guided FNCs, and if they are positive, definitely the management depends on that. Otherwise, if it's negative, then even the more invasive mediastinal or thorough mediastinal staging by mediastinoscopy, I think it should
Right.
be
So,
done.
Dr. Vikas, what's the size of the lesion here?
I believe it's not mentioned here, but it
Okay,
looks like
but-
around 2 to 2.
Yeah, like
Yes, 2 to
till
3, right.
T1, if it's too
Right.
peripheral or less than 3 centimeter, there we do have an option of
Right.
skipping the
Right.
invasive mediastinal node staging. Otherwise, I think all staged
Absolutely.
T2 onwards tumors
Right.
should be staged properly.
And I would like to also add one point here, just like to make a point that according to our standard definition, this lesion looks like a central lesion. It's not a peripheral lesion. If we see it,
Yeah.
so it qualifies for a EBUS definitely. Even though the reporting is not suggestive of any mediastinal nodes, I would like to get a EBUS done in this patient.
Very well said. So we have do
Because you are not audible.
Hello.
and both of our panelists, the surgeons, are going invasive for it, going for a bronchial staging for it. How many times do you find that a mediastinal node negative becomes a positive after first Dr. Abhishek, followed by Dr.
Yeah,
Joseph?
it's. I mean, it's not that common, but still, we do get cases which have been reported negative in a PET scan, and then it comes positive in a EBUS. So yes, definitely, we do get such scenarios.
Yes, sir.
I mean,
uh,
the negative predictive value of PET here is not that great. So you have to always, as it is a central lesion, so definitely you have to get a invasive procedure like EBUS, so to get the nodes biopsied or FNA.
Yeah, I do agree. The PET scan, the problem is both the high false positive as well as false negatives, even up to the tune of 25% cases. Though I routinely don't see too much extent, but yes, I do think that till I think 10 to 15% of the cases, the invasive staging will definitely gonna change the things over the PET scan report.
If the lesion is small and peripherally located, then and mediastinal lymph nodes are negative on CT scan, then how it is common to have a mediastinal lymph node positive on mediastinoscopy? That is my question.
Yeah, so that's the same thing which we already discussed. Like if it is less than 3 centimeter peripherally
Peripheral,
located tumors, okay, then probably we may skip
we can
the
skip. Right.
invasive,
Right.
especially the mediastinoscopy, though the EBUS and EUS still can be attempted.
Right.
Agreed.
But this looks like a central lesion. I hope everyone agrees with me as well.
Definitely, sir.
Right.
So our surgeons are definitely jumping for it, and I believe the radiation oncologists are not right now behind the race. Right now, they are also in the panel, and they also deserve something to be said. I asked Dr. Sonu here. Looks a very juicy tumor. I shouldn't say that works, but then again, for you to do an SBRT for the same. Do you want to do any further investigations, Dr. Sonu? And what's your take on proceeding towards the SBRT? The person has gone to the surgeon. The surgeon has advised him the EBUS and followed by the standard surgery. They have come for your opinion. What's your take?
Sir, I would like to suggest if the patient is healthy and is able to go for surgery and is surgically fit, then he can choose to go for surgery for the cure, for the 100% cure, what we are suspecting. And if the patient is having the poor performance scale and is not willing for surgery, then we can go for SBRT, which is equivalent to the surgery. It will give equivalent results as the surgery will give.
So great to hear that from a radiation oncologist.
That's a very diplomatic answer, and probably for the last
See,
many panel
Vikas
discussions, I haven't heard that answer.
Dr. Vikas,
Yes.
the only problem for me with SBRT in such cases that we are not able to sample and know the status of the lymph nodes. That is the only issue for me.
I totally, absolutely agree.
Right.
But I believe, Dr. Sonu, does your husband is a surgeon right now? Because the way you are practicing right now, I believe that's
No, sir, he is not a surgeon.
He's a thoracic surgeon. He's a robotic thoracic surgeon.
No, sir.
I think the message is quite clear.
Right.
Here, Dr. has already talked that if the patient is inoperable, the option of SBRT come. Otherwise, the first choice or the preferred choice will always be surgery if the patient is physically fit to be get operated.
Very well said. So we have right now a mediastinal staging done. We have got negative everything. Patient is planned for surgery tomorrow. Dr. Abhishek followed by Dr. Kishore sir.
Yes.
Is there any investigation would you like to do before proceeding with the surgery right now?
Yes, we routinely get a pulmonary function test done. What's the age of this patient? Sorry, I forgot.
He's 67. So otherwise,
Okay.
lungs also looks not much bronchiectatic. So I believe that
he's a non-smoker as well. Right. So
Yes.
so we routinely get a FEV1 and DLCO done in all our patients. And if the performance status permits, the cardiology status and the general fitness of the patient permits, we'll definitely like to go ahead with the surgery. And in this case, since this is a more than 2 centimeter lesion, I would plan a lobectomy, a left upper lobectomy, either open or minimally invasive, whatever the expertise of the surgeon is available, along with a systematic mediastinal lymph node dissection.
Dr. Kishore, would you agree,
Yeah,
or would you?
definitely the same thing which Dr. Abhishek has already discussed. The patient physical fitness has to be evaluated first by the pulmonary function tests and the cardiopulmonary status by ECG and 2D echo. And definitely the smoking cessation advice has to be given prior to the surgery.
Right.
Well
And also,
advanced to the surgery.
if right.
And the surgery which he has already discussed, the
Right.
standard surgery in this case would be a left upper lobectomy with the lymph node dissection.
Right.
Very well said, sir. It's just that we always we have a PET negative right now for the systemic metastasis, but it's always, I believe I'm entering into the gray area again. MRI brain contrast. So, do you routinely practice MRI brain contrast in such patients?
Yeah, we get it done only for stage, I think stage 1B to 1B onwards, stage T2 and above.
Dr. Kishore, you also agree that
Yeah,
before
definitely. Like
moving
it's
away
been
from the surgery,
even mentioned in the NCCN panel
Yeah,
of
stage 1B
investigations.
onwards.
Also, even the PET-CT report usually can miss the asymptomatic brain mets. So T2 onwards is an option to get a brain MRI. I usually routinely don't do, but yes, I think it should be done. Has it been there in the NCCN panel of recommendation?
so very well said right now, and our surgeons did a wonderful job. We skip to 4 slides ahead right now. We have done the standard surgery, and that can we shift to 4 slides ahead? 4. Next. So you're going previous. Next. Ahead. Next, and next. Next, and then next. So that's the surgeon's take right now, and we
Okay,
have
so
right
this
now
is T2
with
and
us. Yes. So
right.
the lymph node, which was negative on PET, which was negative on EBUS, has finally propped up in the final specimen. It is a T2N1 lesion with an invasive adenocarcinoma acinar pathology. The report goes to now the medical oncologist forum. We have Dr. Rohit with us. Dr. Rohit, we have right now this T2N1 lesion with us. What more would you like to get out of this thing, and what will be your advice for the patient?
So I like to do EGFR as well as PDL1 on this patient on the surgical specimen, and accordingly I'll plan my adjuvant chemotherapy or targeted therapy.
So, irrespective of you wait for those reports, or you straight away start with an adjuvant chemo followed by tablets or immunotherapy as you want it, or it's just that you wait for these reports and then take a call, because patient has right now the sutures removed, everything fine, the wound is all well, the surgeons did a beautiful job, they went ahead with a robotic surgery, and you can't file which way the incision went.
But the thing is that the patient is non-smoker, and there is high probability that he may come EGFR positive. If he is EGFR positive, then why to give chemotherapy? We'll go with adjuvant osimertinib. And if he is EGFR negative, then we have the option of chemotherapy or adjuvant pembrolizumab also, despite of PD-L1 status.
Very well said. Dr. Tarachan sir, you would also like to agree, or you have some other opinion right now?
As I have any choice or to disagree with Rohit, I have to live in Jaipur, So I am agree with Dr. Rohit.
You may always disagree with me.
So I am agree with Rohit that we should go for the at least EGFR testing, and then we can plan accordingly.
Right.
Very well said. So next slide, please. And here comes the slightly contradictory opinion. So what sample would you choose for your molecular testing? Will it be a pre-surgical sample, that is the diagnostic which they did for a biopsy, or you want it on a post-surgery specimen uh, for it? And the second question is, apart from EGFR and PDL1, a common reflex in our system is to add ALK to the specimen. So, Dr. Rohit answers to these two.
So my answer is I'll go for the post-surgery tissue. I'll go for the surgical specimen. I'll go for EGFR, ALK, as well as PDL1. These three will be my markers. And EGFR is for adjuvant osimertinib, and ALK, we don't have any kind of approved therapy at present, adjuvant therapy for ALK inhibitor. And PDL1, we have atezolizumab and chemotherapy. So definitely post-surgical specimen, because you have lot of tissue. There is no chances of getting any tumor heterogeneity. And for EGFR, we have therapy, and for PDL1, we have therapy.
Very well said. Dr. Tarachan sir, supposedly we have right now the report of PDL1 as 90%. Would you start the first dose of immunotherapy, or you would still wait for the EGFR report for the same patient?
Yes, I will wait for the EGFR report also. And if we are offering ALK testing also, then I will wait for that report also.
Very well said, because yes, both of these reports, why our medical oncologists are so persistent about it. We'll move to 4 slides ahead right now again. So adjuvant chemotherapy for non-small cell lung cancer across all regimens BVC, when we use adjuvant cisplatin, the margin of benefit is 5-year overall survival advantage is only 5%. Whatever the chemotherapy background we use cisplatin, vinolbin, pamitrexate, vinolbin. The LACE meta-analysis have shown consistently that whatever the regimen which we choose, the four trials which were 5 trials which were taken into that, all of them showed that the 5-year overall survival benefit of addition of the chemotherapy is 5% stage by stage. And that's where this EGFR mutation does come into play. The ADORA trial, which we all adore, has shown us an impressive DFS benefit right now with a hazard ratio of 0.2, meaning an 80% reduced chances of disease regression, disease progression with the same. And that's where I believe it is important that we take into this ADORA trial into our practice. So, Dr. Rohit, please 5 slides ahead. Dr. Rohit, how much years of adjuvant osimertinib do you practice? So, patient has undergone a radical surgery right now, and he has all the guns. So he asked on the day one that I have to calculate my expenses for the same. Adjuvant osimertinib, how many years? We have a DFS data. The OS data is still awaited right now. So, Dr. Rohit, how many years of osimertinib you have to
So
counsel?
guidelines is to go for 3 years of osimertinib, and I hadn't experienced any patient who had resection done, potential curable resection done, and EGFR positive, and I have to start osimertinib. But definitely osimertinib is a very costly drug, and if a patient is having some kind of support from any government agency or from any other agency, then definitely 3 years of osimertinib is standard of care. DFS benefit is there, and I think overall survival is still interim data is there, but still the full overall data is still awaited.
Very well said. 3 years is what is the standard across all guidelines, and that's where it is important that we counsel the patient on day one that we have to give them a 3 year drug. It's not just a month or 2 months or 6 months or 1 year from now. And we have with us the radiation oncologist also. She has been silent and she has quietly reflected on the SBRT talk, but we won't leave her on adjuvant radiation part also. So this patient does have a node positivity, and I don't know why they are not moving the slides behind, but I believe they want you to be more involved. So would you like to give an adjuvant radiation to this patient?
No, sir. Only adjuvant chemotherapy or immunotherapy.
My
Margins are
God.
negative, so that's why there is no need for post-operative.
Very well said. I must say that this is one of the quietest radiation oncologists we have seen right now. We have discussed, I would like to get a review done. We have discussed probably the lymph node sampling was not adequate or something like that. But that's a brilliant answer, I would say, because the margins are negative right now, and that's the concise thing right now. Dr. Tarachan, sir, do you think osimertinib has, in adjuvant settings, has changed the way we practice the
Yeah.
early stage lung cancer?
Yes, osimertinib, because first of all, we go with the common perception that the chemotherapy is toxic, so the patient usually try to avoid it. Even we explain many times the benefit of chemotherapy, so they find that the surgery done, tumor removed, then why the chemotherapy? So they try to find the way where they can go with the less toxic regimen. And osimertinib is, yes, most of the time it is well tolerated. So it's a good option if the patient is EGFR positive. And other ways are also there that if the patient is PD-L1 positive, then can go with the pembrolizumab or atezolizumab. They are usually well tolerated, only the 5% with the 5% toxicity only. So it is the way where patient and even the physician is also comfortable that he doesn't not need to monitor the patient for the chemotherapy or again and again. But the unfortunate thing is patients usually come in a stage 3 or 4 where the surgery is usually not cannot done in the last 5 years. I've seen only 2 patients only post-op. One of them was MET positive, not the EGFR, and one was not affording even for the chemotherapy after
Yeah.
the surgery.
Dr. Vikas, I have just one question for the medical oncologist. Just wanted to know the current scenario about the adjuvant atezolizumab, the Empower study trial, which proved. So what's the current status right now? And another thing is osimertinib preferred or is atezolizumab preferred? What's the current status right now regarding this?
I'll take that question. If so, actually, if EGFR positive, definitely we'll go for osimertinib.
Right.
And if it is PD-L1 more than one, then it depends whether the patient is affording or not. If he is affording, then they can give cisplatin or platinum-based chemotherapy along with atezolizumab, followed by 16 cycle of atezolizumab.
Okay.
Yeah, but still there is
Sir,
DFS
request you
benefit.
to kindly conclude your
There is still
panel discussion.
DFS benefit. There is no overall survival benefit at present because
Right.
the overall survival benefit is still not mature at present.
Okay. Okay.
Very
Thank
well
you.
said by Dr. Rohit sir, because yes, Adara has shown a beautiful trends right now and it has become practice changing. Adjuvant eccentric is something which we will always tend to debate till we have a final overall survival. But definitely the higher the stage is, so 2 and 3, the magnitude of benefit of the DFS is quite high. And that's where we believe is a potential exploration of giving an adjuvant atezolizumab. And I really wholeheartedly thank all my panelists for a beautiful panel discussion. Dr. Tarachan, Dr. Rohit, Dr. Sonu, Dr. Kamal, Dr. Abhishek, Dr. Rohit, and I give over to the organizers for further talk. Thank you.
Thank you, Dr. Vikas. Thank you. It was a wonderful session.
Thank you, panelists.
Thank you, everyone. Thank you.
And a special thanks to Dr. Vikas for last time's call and moderating the panel beautifully. And it looks like that it was already prepared by Dr. Vikas and it was
Yes,
switched just.
absolutely.
So thank you, Vikas, again, and it was nice. Now we are moving towards the next talk, and I invite Dr. Rohit Rovelo for next talk on role of alectinib in ALK positive non-small cell lung cancer. Dr. Rohit Rovelo, please.
Thank you, sir. I'll share my slides first. Are my slides visible?
No, sir.
No, sir.
No. Okay, now they must be visible, right?
Yes, sir.
Sorry.
It's loading.
I'm sorry. I'll just. Am I audible and visible?
Sir, yes, you are visible, but
Slides now?
yes, sir, it's visible.
Okay. Sorry about that. Good evening, everybody. So I'll be taking this presentation on the role of alectinib in first-line ALK-positive non-small cell lung cancer, with a special emphasis on ALEX and the ALICIA study. So the content, again, the disclaimer, this has been provided to me by Rosh. So we'll go through it with these particular headings: overview, ALK testing, ALK positive disease, approved ALK inhibitors, and the alectinib molecule itself. So there are 2.2 million new cases of lung cancer that are diagnosed each year. Lung is the second most commonly diagnosed cancer worldwide and the leading cause of cancer-related deaths. And about 1.8 million people of these, do die out of lung cancer each year. So adenocarcinoma happens to be the most common form of lung cancer. So about 83% of all lung cancers are non-small cell lung cancers, out of which 43.3% happen to be adenocarcinomas. So the incidence and mortality in India, as per data from 2020, shows that there are 72,000 new cases every year and about 66,000 deaths per year that occur amongst lung cancer patients, with it being the most common cause of death amongst men. So routine testing in clinical practice of EGFR and ALK mutations is recommended by various guidelines, especially for the adenocarcinoma histology. Identifying the molecular profile of a tumor, it facilitates a better clinical decision making, as knowing the driver mutation is significantly important today, because immunotherapy has a great role. Targeted therapies in lung cancer have managed to be game changers in improving the progression-free survival as well as the overall survival of lung cancer patients. So ALK testing is basically done by FISH, immunohistochemistry, RT-PCR, or next generation sequencing. What we currently do in our institute is we kind of prefer to do next generation sequencing, because you get more accurate results, as well as you are able to get a wide range of coverage of the various mutations in lung cancer with a small amount of tissue. So if you look at ALK mutations, the numbers are almost similar when you consider it in between different parts of the world. It's between about 3 to 5% globally. So it's about 5% of all advanced non-small cell lung cancers happen to be ALK positive lung cancers. So the incidence of ALK positive non-small cell lung cancer is higher in patients with non-squamous histology, never a former smoker, younger patients, and females. Patients who do not have EGFR or KRAS mutations. Clinical characteristics do not always predict the presence of ALK positive lung cancers. So the ALK gene technically undergoes rearrangement within the chromosome, and the rearrangement results in structural alterations of the chromosome and an expression of an ALK fusion protein. The rearrangement was first discovered in a subset of patients in 2007. So it's reported in about 7% of the lung cancers, which are found more commonly in young patients with adenocarcinoma and history of never or light smoking. How the incidence has been variable across different regions in India. So these are the currently approved therapies for ALK positive lung cancer. Started with crizotinib, and now we have the third generation lorlatinib, with alectinib and brigatinib being the second generation ALK inhibitors. So if you look at the median PFS, it keeps on increasing as you go from each generation to the next generation, and below is the dosing of each of these drugs. So if you look at crizotinib, the Profile 1014 study showed that it improved the progression-free survival from about 7 months to 10.9 months with a hazards ratio of 0.47. The final overall survival analysis showed that crizotinib patients had a 4-year OS of 56.6% as compared to chemo of 49.1%. The side effects of crizotinib are mostly gastrointestinal, with diarrhea, nausea, vomiting, and causing major issues in compliance of the patients. Ceritinib, like crizotinib, demonstrated a significant PFS benefit in the SN4. As you see, the PFS has become from about 9 months, it's gone to about 16.6 months when ceritinib was compared with chemotherapy. Here also, you see a lot of gastrointestinal side effects, with diarrhea, nausea, and vomiting being the most common adverse events. So crizotinib and ceritinib are actively exported out of the blood-brain barrier. So the CNS exposure of crizotinib and ceritinib may therefore be inadequate to control the disease in this location and the CNS from a sanctuary site of tumor growth. So if you look at brigatinib, the ALTA-1 study also showed an improvement in PFS from 16 months, what we saw with ceritinib, to 24 months as compared to 11 months. So when brigatinib was compared to crizotinib, there was a significant almost doubling of more than doubling of the progression-free survival benefit. So when you look at the lorlatinib population, again you see that there is a significant benefit in the progression-free survival. At 36 months, when compared to crizotinib, it is 63.5% versus 18.9%, with the median PFS not yet being reached in the investigator arm. But however, one must note that there is a significant problem with hypercholesterolemia, but that's kind of easy to manage, not that hard. But the most significant toxicities that is seen with lorlatinib is the CNS toxicity, and this is one of the reasons that most of us are very scared to use this drug, because it does cause a lot of cognitive, mood, and speech defects, and can also cause suicidal tendencies in patients. So the key features of alectinib are: it's selective, it's potent, it acts against quite a few resistance mutations, has good CNS penetration, and is a safe molecule. So there are multiple studies that have proven the benefit of alectinib from phase 2 to phase 3. So the JLX study was conducted in Japanese patients. The ALEX was a global study, and the Alicia study was a phase 3 study in treatment-naive Asian patients with ALK-positive non-small cell lung cancer. So in the ALEX study, what they did was they randomized alectinib 600 mg BD to crizotinib 250 mg BD, and until progressive disease, toxicity, withdrawal, or death. So the stratification factors were CNS metastasis at baseline, Asian, non-Asian, and ECOG status, and the primary endpoint was PFS with other secondary endpoints. So in the third exploratory analysis, which was done on 29 November 2019, with a follow-up of about 48 months, this publication showed that there was a significant benefit in progression-free survival in the alectinib. Obviously, it also had a better profile when you consider lung metastasis. So if you look at the PFS estimates when alectinib is compared with crizotinib at 36 months, it is about the median PFS is about 34.8 months as compared to 10.9 months with crizotinib. So there is a proven benefit of protection from disease with about a 3-year progression-free survival. So in patients treated with alectinib, 43.7% of the patients were event-free at 4 years. The 4-year event-free rate was not estimable in patients with crizotinib treated disease. So you can see that it favors all groups in this particular plot, and even brain metastasis patients did better with alectinib as compared to crizotinib. So if you look at the secondary endpoint, that is PFS by baseline CNS metastasis, that is in patients with pre-existing CNS metastasis, the PFS was 25 months, and without, it was 38 months, as compared to 7.4 and 14.8 months. So it is a protection that lasts years, irrespective of CNS metastasis at baseline. So definitely patients without CNS metastasis did significantly better. The cumulative incidence of CNS progression also was lower in case of alectinib as compared to crizotinib at 44.1% with alectinib and 9.4% with crizotinib at 1 year. So both alectinib and crizotinib achieved a high overall response rate. However, the duration of response was longer in alectinib, suggesting a prolonged response, which appears to translate into significant PFS benefit when alectinib is compared with crizotinib. So the investigator assessed significant best responses. You see, the depth of response is also significantly better when you compare alectinib with crizotinib. Although crizotinib does have good responses, but the depth of response, you can see, it is definitely more with alectinib. So the duration of response also was found to be more at 33.1 months as compared to 11.1 months. So CNS progression in patients without prior systemic disease, that is treatment of alectinib, significantly reduced the risk of CNS progression in patients without this disease at baseline. And as we all know, ALK has a propensity to actually go to the brain. So that is one of the most common sites of failure in ALK-positive patients. So the best overall responses to measurable and non-measurable baseline CNS responses were also significantly better with alectinib as compared to crizotinib. So the tumor reduction also, if you look at more than 75% and more than 50% tumor reduction, especially in measurable or non-measurable CNS responses, they were also better with alectinib as compared to crizotinib. So it at first line, when you look at the ALEX study, which has 5-year OS data, so alectinib first line has a more than 60% OS rate at 5 years, which is one of the highest when in any ALK positive therapy. So 6 out of 10 patients are alive at 5 years. So 62.5% versus 45.5%. So these are the 5-year survival rates. Where alectinib showed a 5-year survival rate of 62.5 as compared to crizotinib of 45.5. One needs to know that the global ALEX study actually did not allow crossover from crizotinib to alectinib. So these are the major side effects that occurred. If you look at grade 3 to 5 adverse events, about 52% and about 56% in the crizotinib had this sort of side effects. So the side effect profile is slightly different in case of alectinib as compared to crizotinib, where crizotinib has more amount of GI side effects, where alectinib has a lot of these arthralgia, muscle pain, myalgias, which are actually the main symptoms that the patient tends to complain to you with. So there are no new safety signals were discovered in this study. So it has now become the first line therapy of ALK positive non-small cell lung cancer as per the latest NCCN guidelines. So the LNCR study, LNCR is preferred first-line treatment option standard for ALK positive non-small cell lung cancer, because you have a good median PFS of about 34.8 months as per the ALEX study, and the ALACIA study showing 41.6 months in the first-line setting. It protects against and treats CNS metastasis as seen by the objective response rates in both the study. And it is the only TKI to have demonstrated a clinically meaningful benefit in OS versus crizotinib, and is well tolerated with a well-characterized, manageable safety profile that is maintained and with long-term use. ALEX data confirms that alectinib shows superior investigator-assessed PFS, longer duration of response, impressive CNS efficacy, and it has the NCCN Category 1 preferred treatment for ALK-positive first-line lung cancer, metastatic lung cancer. So the ALACIA study again compared alectinib with crizotinib with a 2:1 randomization, which in Asian patients who had treatment naive, and the median duration of follow-up was 61 months with alectinib, 51 months with crizotinib. So they were well matched between both groups, and the PFS, if you see, there's a significant gap between the two curves, and that starts from about 3 months and then continues till about 60 months. So the median PFS was 41.6 months compared to 11.1 months, with a hazard ratio of being a very impressive 0.33. So this is consistent with the global ALEX study, where the median PFS was 34.8 months with alectinib and 10.9 months with crizotinib. So patients, if you look at CNS status at baseline, with CNS mets at baseline, the PFS was 42 months, and without they were 41 months. So there was not a significant difference between the progression phases. So it works well even with patients who have CNS metastasis, as it has good CNS penetration. So the OS data remains immature, and the clinically meaningful improvement in 5-year survival with alectinib versus crizotinib was demonstrated, with alectinib having a 5-year OS of 66.4% versus 56%. So this is a very forgiving disease where almost 2/3 of the patient actually survived to 5 years with stage 4 lung cancer, which is something we could not dream of during the age of chemotherapy. So the OS data tends to be immature, and the OS benefit of alectinib versus crizotinib was observed irrespective of CNS mets at baseline. So the time to CNS progression also was, if you look at the hazards ratio, it is 0.16 when alectinib was compared to crizotinib. So these patients tend to progress at a much slower rate to CNS metastasis as compared to patients on crizotinib. And if you look at the post-progression therapy, so in patients who received crizotinib, almost 30% of the patients actually received alectinib in the second line. So on progressive disease also, there was about a 30% crossover, and that probably contributed to not finding a significant overall survival difference. We have already gone through these. There were no new findings. So with at least 5 years of follow-up, alectinib 600 mg BD contributes to a demonstrable clinical benefit in Asian patients, with a median PFS of 41.6 months for alectinib versus 11.1 months for crizotinib. The PFS benefit was irrespective of CNS metastasis at baseline, and it delayed the time to CNS progression, and clinically meaningful increase in the 5-year survival rates were also seen. Thank you.
Thank you, Dr. Rohit, for a wonderful talk. Again, a common question which is asked for the ALK-positive lung cancer. What is the choice between lorlatinib and alectinib of yours for the ALK-positive non-small cell lung cancer, and why?
So lorlatinib has quite bad CNS toxicity, sir. Also, the problem with so we know that lorlatinib given after alectinib works, but the data for alectinib given after lorlatinib is very shady, and it might not work because lorlatinib covers most of the resistance mutations, secondary mutations that develop on a patient with alectinib therapy. Now, the overall survival data, if you look at the crossover, right, is almost similar when you sequence alectinib first and lorlatinib later, and we don't have mature overall survival data for lorlatinib yet. So because of the CNS toxicities, I think most people prefer using alectinib first, especially in patients without brain metastasis. But I think in a patient with brain metastasis, lorlatinib tends to be a better molecule.
Yeah, so you are saying that if the patient is not having brain mets, then the lorlatinib is a better option than alectinib in ALK-positive.
I see generally what happens is lorlatinib, it protects the brains. Or if you look at that curve of lorlatinib with the patients who did not have brain metastasis at baseline, it is flat. So it actually protects the brain more significantly. So in these patients who do not have brain metastasis, giving lorla I think is better. But obviously you have to manage the neuropsychiatric sort of side effects, which actually in real world data is far higher than what Crown said.
So we will discuss this topic again in the lorlatinib talk again after a few minutes. So I think you will be there today for this a good debate. So before that, there will be there is a good panel discussion now. Next is management of uncommon mutations in lung cancer, which will be moderated by Dr. Akhil Kapoor from TMH Varanasi, Senior Medical Oncologist and Assistant Professor at Tata Memorial Hospital, Varanasi. For this panel discussion, panelists are Dr. Preeti Agrawal, Jaipur, Consultant Medical Oncologist, Narayana Hospital, Jaipur. Dr. Aditi Mittal, Consultant Medical Oncologist, Apex Hospital, Jaipur. Dr. V.S. Ankit Nera is a Consultant Medical Oncologist at Renova Group in RHL Hospital, Jaipur. Dr. Lalit Sharma, Senior Consultant Medical Oncology, Manipal Hospital, Jaipur. Dr. Jitendra Pahlazani is also a Consultant Medical Oncologist at CG Cancer Center, Jaipur. So over to you, Akhil.
Thank you, Tarachan boss.
And Dr. Sudhir Palsania is also there. Sorry, I forgot the name. Dr. Sudhir Palsania, Consultant Medical Oncology, Shalvi Hospital.
Thank you, Tarachan boss, for inviting me for dealing with this topic. This is an important problem in our practice. EGFR being a very common mutation, but we get commonly the uncommon mutations as well. So knowing it to be uncommon, but actually if you see the number of patients which we see in our country, it is not so uncommon for us. So first question is, how uncommon is the uncommon mutation in our practice? Let's start with our panelist. I request everyone to actively participate, and if feasible, also switch on their video so that we can have interactive discussion and we can see each other. So yes. So Dr. Lalit would like to comment on this.
Well, this is something which, as you rightly pointed out, with the more and more use of broad-based panels on the NGS, we are seeing comparatively more frequently as we would have thought earlier on, when these broad-based panels were not used that frequently. But still, majority of them would turn up with deletion 19 and L858R mutations. But more and more use of NGS, definitely the rarer mutations are turning up more frequently on our tests.
Very pertinent point. The increasing use of NGS has definitely led us to recognize more and more uncommon mutations. The reason is that whatever the advanced RT-PCR you may use, for example, we are using COBAS version 2 of RT-PCR for EGFR, but we can detect only 42 types of mutation with that COBAS version 2, which is the most advanced version. With if you see NGS, we can detect at least 50 types of exon 20 insertion mutation only. So at one point, RT-PCR is able to detect only 42 types of EGFR mutations. At the same time, NGS is able to detect at least 50 types of exon 20 insertion mutation. Forget about common exon 19, 21, other exon 18 mutations. So that means, yes, that is one of the reasons why multiple new mutations have been recognized, and we are able to deal with such many mutations. And we have to search now. Every time you find an uncommon mutation, it is now we have to search the net for finding what is it and is had been reported or not. So it is not a very easy job now, that nobody can remember each and every mutation names. Previously, there were only 3 or 4 mutations which everyone remembered, but now it is not so easy job. Dr. Preeti, how is your experience of uncommon mutations? Do you find it routinely in your practice now?
Yes, as the use of NGS is increasing in our practice, so we are it is not rare to find uncommon mutations these days.
Yeah, so rare mutation is not actually rare these days, especially
Yes.
Completely agree with you, Preeti. Thank you. So let's start with the case. This is a 63-year lady, non-smoker, breathlessness, diagnosed with lung metastasis with primary lung lesion, biopsy suggestive of adenocarcinoma. The PS was 1. We would all agree that we'd like to do broad panel NGS, especially incorporating both DNA and RNA-based NGS, because we know we want to detect more and more mutations. At the same time, we don't want to miss fusions. So DNA plus RNA-based NGS, that is now our routine practice. We now send at least 52 gene panel in our practice now. We have stopped using 5 gene or 9 gene panel, or even 12 gene panel we have stopped using. We have multiple trials ongoing. We have trials for exon 20, we have trials for HER2 mutation, we have trials for RET mutation, we have trial for ROS, we have trial for KRAS G12C, 3 trials. So in lung, we have 17 trials ongoing. So we want to find one or the other mutation so that a patient can get the benefit of the ongoing trials at our center. So that is what we do in our practice. I think most of them will agree. However, yes, the cost is an important concern. We want to do the best for our patients, but it might not be always feasible. So that depends on various scenarios. So let's see about EGFR. Yes, as we are aware of these, this is the most common EGFR 19, 21. Apart from that, we commonly see T7 and TM as well, especially after progression on first or second line TKIs. Then exon 18 and exon rare exon 20 insertion mutations. So this patient actually got this mutation. You can see on the NGS report, there was a compound mutation, L858R was present. Apart from that, there was a S768I mutation was also detected. So yes, it's a compound mutation. S768I was found apart from having a mutation in exon 21. So what should we do now? Dr. Lalit, would you like to comment?
One, I don't think reconfirming from the other lab is going to help very much until unless you have got a report from a lab you haven't heard of. Now the mushrooming of these labs and the validation or calibration of we are not very sure. But if it is from a reliable lab, I would probably scratch my head and look into my PC for what particular mutation this is and whether it is sensitizing or not, rather than questioning the lab itself. So for the lab part, I would be rather more rely on the test. Second part is what to do then is probably in case this is a sensitizing mutation, if I remember it correct, probably for the rarer mutation, afatinib probably has a better response rate compared to osimertinib. So I would probably prefer afatinib provided the patient's performance score is okay and there are no major comorbidities, because with afatinib tolerability is always kind of consideration for me, at least. I haven't found this molecule to be easy to kind of handle.
So well highlighted point, but the point highlighted is very important. At the same time, all rare mutations might not be sensitive to afatinib. That is what we want to know completely. That is why it is always better to discuss such cases in molecular tumor board if possible. So we conduct molecular tumor board thrice a week now. We discuss around 30 to 40 cases in a week now because of the large number of the cases, and we discuss only the cases which are apart from the common mutations detected. So yes, there are so many plethora of data which nobody can be aware of, and it is not possible for a full-time clinician to remember each mutation, and it is not humanly possible. So the role of AI also coming up to assist the medical oncologist, because we are dealing with a complex field, and also our molecular oncologist, if there are any in the hospital, they might help us by utilizing the various technologies and the ClinVar data and other databases. So let's take comments from our other colleagues. Dr. Sudhir, what do you think? In such situation, there's one option of afatinib. What is your other option? What do you think in routine practice? Utilizing options like chemo plus gefitinib is considerable, or you'd like to utilize osimertinib? What are the options in your mind?
It is exon 20 mutations actually. So there the osimertinib, there is very less response for the osimertinib, even is the 160 dose also. So there is a role of chemotherapy obviously, then the afatinib, and there the dual mutation is there. So there is a role of osimertinib, and newer molecule also ematinib also for this exon 20.
Yeah. So it's a compound mutation. Nobody
ematinib.
Amivantanib. So there is no clear answer, because this is a compound mutation. So one mutation might be sensitive to one drug, other mutation might be sensitive to other drug. So we need to take decision accordingly. So here the problem is the patient is having compound mutation with exon 20 and exon 21. How to go about it? Nobody knows the exact answer. There are multiple data, multiple studies which suggest exon 21. This we all know, but exon 20 difficult to get to one answer. So these are just, I will highlight the various studies available. Afatinib, as highlighted by previous panelists, that it has some activity on the rare mutation. That is why it has been approved option, FDA approved label for G79X, L861Q, S768I. But point to be noted is that L861Q, this does not have very good activity. It is still, response rates are not very high, and that PFS will be tune of 7 to 8 months only, even with afatinib. So we need to think what we can do further for these patients. So
can I ask a question?
Sure, please go ahead.
What does the panel think of while considering the compound mutations, which is actually the driver mutation? What all factors do we consider?
Yeah, so let's take comment. Preeti, would you like to take this? Any comment on the VAF, the relative number of mutations, any VAF high? What is?
Yeah, VAF is also an important factor. So what type of mutation in what is the VAF of which type of mutation? So that is also an important factor to be considered. But there is no enough data to support like which is the target mutation in this thing.
Completely.
So it is a basically hit and try.
Yeah, it's a basically hit and trial method. VAF gives us some idea. That is the advantage of doing NGS, because we get to know what is the VAF. Otherwise, in RT-PCR, you will get the report that exon 20 is positive, exon 21 is positive, or exon 18 is positive and exon 19 is positive. Then we don't know the actual answer. But here, at least VAF will give us some idea. So if we come back to the case, the VAF for this patient in exon 21 was to the tune of 17%, and with exon 20, the S768I, it was to the tune of 22%. So it seems to be having S768I was also a significant one. That is, so for S768I, we know afatinib activity is good, and afatinib also has activity on both exon 19 and 21. So that is why in this patient, actually, afatinib was selected, and the patient was initially started on 30 milligram and escalated to 40, and a scan at 4 months suggested of responding disease. So yes, this is a case which highlights the importance of knowing the variant allele frequencies and utilizing it for deciding the practice. So there might be different interpretations, there might be different options, but yes, this is what happens in the real practice and we want to interpret. Dr. Ankit, you want to comment on this?
No, sir, I totally agree with Preeti ma'am, because there is a there is a complex mutation. So rather than going with the third line TKI as well as third line TKI has a phase 1, phase 2 data of giving a PFS of around 5 to 7 months, but second line TKI in compound mutation is already always better, and VF is just VAF is just a preclinical in the preclinical phase as well. So I totally agree with this second line generation TK.
Thank you, Dr. So let's move to another case. A 78-year gentleman diagnosed with metastatic lung disease. Biopsy showed adenocarcinoma, and it was positive for TTF1. Primary pulmonary adenocarcinoma started on nab-paclitaxel due to high symptom burden. The tissue was sent for NGS. It was small gene panel, 12 gene with Ventana SP142. That this uncommon exon 19 mutation was identified with VAF of 61%. If you see, this is S740 to 745. So here I would like to highlight one important point, that most of the common mutations in EGFR occur between, if you see, it occurs between 745 to 769. And beyond that, it is the uncommon mutation is even in exon 19 can occur. So this patient, you can see from this report, 750 to 745 it was involved. So how to deal with this? This is a exon 19 mutation, but still it is not the usual exon 19, which is might be very sensitive. Let's take comments from our other panelists as well. Anybody would like to take it forward?
So this is not the routine. Hi. Yeah. This is not the routine exon 19 deletion, which we see as sensitizing mutation. This is the insertion mutation, and we don't know whether the this EGFR TKI would be effective in this case. So I don't know whether there is data to use any TKI in this type of insertion mutation. I would rather use a chemotherapy.
You will rather use a chemotherapy.
Yes.
So yeah, completely agree. So this is a very good option. And actually in our practice, we utilize chemotherapy plus gefitinib in such patients for uncommon EGFR mutations where there is no clear-cut data. We try to utilize chemotherapy plus gefitinib because we know that that is a tolerable combination in our practice, unless the patient is very frail, patient is having multiple comorbidities, then it might be difficult to tolerate. But otherwise, chemotherapy plus gefitinib might be a good answer. That is what being utilized in our practice. Any comments from anyone else who thinks differently or treat this patient differently?
Yes, I totally agree. Yes, sir, please go ahead.
अंकित बोल कोई बात नहीं तो
नहीं sir, I totally agree with sir. I usually treat with these patients with the combination of chemotherapy with first line generation, either as gefitinib or erlotinib. Gefitinib being more tolerable drug, so chemotherapy with PAM carbo with gefitinib is my first go, because we do not know how the again the second line generation TKI will work.
Yeah. Let's take comments from Dr. Jitendra as well.
Yeah, I was telling that once you check the mutation, whether it is a driver mutation or not, and if you find out that this insertion, particularly what we are discussing about, if it is not a driver mutation, then I think probably chemo immuno plus BAM, that should be the thing to go. If the mutation is not driver, if your molecular analysts say that it is not a driver mutation, then probably it is just another mutation which is there by chance. Then adding gefitinib to chemotherapy will not give us anything.
Yeah, but definitely EGFR exon 19, though it is an uncommon EGFR exon 19, it is a driver mutation actually. This was discussed in our molecular tumor board as well. And we find such mutations which are beyond the usual exons of 745 to 769. So yes, these are important to know. And that is why this patient was treated with not a usual single agent TKI or chemotherapy alone. This was treated with chemo plus TKI, that is gefitinib.
Again, I think Dr. Charu, well, molecular pathologist is also there. I think we can call her. Yes. I think Dr. Charu, well, is also there.
Yes, sir. Yes, sir.
Yeah, Dr. Chori, would you like to give your comments on this EGFR exon 19 uncommon mutation?
Yes, sir. So definitely it's a driver mutation because the VAF is 61%. And even if you look at other than the VAF, you can also look at the tumor content that was there. So we should go back and check what was the tumor content in the sample which is provided. And if you also, another approach could be, if you want to be sure, you can also do a complementary liquid biopsy test just to be sure in terms of tumor heterogeneity that there is no other mutation that is missed out. If you find the same mutation in the liquid biopsy as well, so that will give you more reassurance. And if there is any other mutation that could be there, like in a compound situation, that could be captured through that. Another important point which in the previous case you discussed, I would want to highlight, is when you have compound mutations, you also should look at the mutations whether they are in trans or cis form. So by that I mean that whether the mutations are in the same clone or they are from the different clones. So we can, through NGS data, we can apprehend that. And usually we mention that in our reports that these mutations are in trans form or are in cis form. If they are in trans form, that means they are from different clones, and then they can be treated differently. And if they are from the same, if they are in the same cell, then the treatment approach could slightly differ, because then those mutations are present in the same cell. You are targeting the same mutation in one single cell. So that is, I think, also an important aspect when you treat compound mutations or some uncommon mutations.
Very important point highlighted by Dr. Charu about the cis and trans mutations. Having whether same clone is present in that particular tumor cell, or it is arising from two different clones present in the tumor, because we know that tumors are heterogeneous. Different tumor cells might be harboring different EGFR clone mutations. So that may be one of the reasons to detect. And definitely these things take precedence, and we take cognizance of these points while deciding treatment in our patients. So that is why we always try to discuss these cases in molecular tumor board, because our molecular expert might point to some important comments which can completely change the decision. We have conducted a study where the outcomes of molecular tumor board, the decision of medical oncologist was changed due to discussion by a molecular oncologist in molecular tumor board in around 22% of the times. So that is an important data. The 1/4 times when the decision of a medical oncologist is changing. So that means the selection of the cases which we are discussing, that becomes a very important to be discussed in molecular tumor board. So that is the benefit of discussing in molecular tumor board, as pointed out by Dr. Charu as well. So we are running short of time. We'll just touch a third case where we have found exon 20 insertion mutation. And this has been highlighted previously, that there is data for now osimertinib. Also, there is very good data for amivantanab, though amivantanab trial has utilized in the second line. First line trial, amivantanab plus chemotherapy, the results are eagerly awaited. We all know amivantanab has very good outcomes, efficacy, and we have utilized in a large number of patients till now, both in the second line and also in patients who are willing, after explaining the details, even in first line with high burden of the disease. So this data is very, very important for us, and we are utilizing in a large number of patients. Anyone having experience of amivantanab use? Anyone would like to comment, or else I will share my experience. There are sometimes infusion reactions. This will occur in around 30 to 40% of the patients. That is why go slow with amivantanab. Infusion on day 1 has to be slow. Start with 25 ml per hour rate. Give only 1 vial on day 1 of the infusion. 1 vial is 350 milligram. On day 2, give the remaining doses. The dose is weight based. More than 80 kg or less than 80 kg. Most of the time our patients are less than 80 kg, so 1050 is the dose. So you have to give 1 dose of 350 on day 1, and on day 2 you give rest 700 milligram. So and this drug gives very beautiful responses. We have now utilized in at least 20 patients, both in the trials and outside the trial setting. We have also done compassionate access use for a significant number of patients. So I think if there are some comments or question, we can take that, else I will stop due to shortage of the time.
Can I ask a question to Dr. Charu?
Yeah, please go ahead.
So So far, Dr. Charu, as a clinician, we have this kind of notion that probably the tissue samples are the tissue blocks probably are the better samples to assess, especially on next generation sequencing and all. So now your comment kind of intrigues me that you should probably liquid biopsy or the blood samples probably would provide us additional information here. So could you just identify a few scenarios wherein this additional sampling would provide us with some treatment-based changes or clinical outcomes to be kind of considered, wherein we should consider sending this additional sample?
Yes, sir, definitely. It's a recently upcoming approach which I have actually witnessed with some of the clinicians using it, and the impact of it is mostly in terms of tumor heterogeneity. There could be, I mean, it depends on the probably you can say the anatomical feature of the tumor. If the tumor is bigger in size and you are taking just a few cores from a particular location, then you might miss out on looking for other like mutations in the other region of the tumor, and also good driver potential. And if you are treating only in one direction, you can miss out getting that better outcome which you could have had if you would have done a complementary liquid biopsy testing. So this is one situation where it can be really helpful. Nevertheless, the other thing which we recently encounter is usage of liquid biopsy during the progression of the disease, when the patients stop responding to a very particular targeted therapy. We might find certain important mutations at a very lesser load, which indicates that the tumor might have had those clones at the time of diagnosis only, and they were not picked up in the tissue NGS. So it gives us very different insights to us. It is becoming more and more interesting for us also, and we are also capitalizing on such cases and talking to clinicians to find out the outcomes. So I think it is more of a case to case approach, which can actually, discussing, as Dr. Akhil mentioned, discussing with the molecular specialist can really give you better insights, and if the patient can go ahead for those testings, could be really changing the direction of treatment.
Thank you. Thank you.
Thank you. Thank you.
Thank you, Akhil and our panelists for a wonderful panel discussion. And now I invite Dr. Pramod Kumar for our next talk, management of first-line ALK-positive non-small cell lung cancer. He is assistant professor in AIIMS Jodhpur, and I would request to finish in time his talk. Please, Dr. Pramod.
Are my slide visible?
Yes, sir.
Okay. Good evening, all. I'm Dr. Pramod Kumar, Assistant Professor Medical Oncology at AIIMS Jodhpur. This is my disclaimer. So, I will be discussing on management of first-line ALK-positive non-small cell lung cancer patients. So, this slide represents the development of ALK inhibitors over the last 20 years. And so it's not moving. Yeah. So this is the development of ALK inhibitors in last 20 years. So by now, there are certain unmet needs for ALK positive non-small cell lung cancers. As we previous panelists, previous presenters have said that ALK positive lung cancer patients are younger patient, median age is 51. They are generally non-smokers or light smokers, and the treatment expectation in such set of patient is that the treatment should provide a longer and a better disease control. However, as we all know that ALK positive lung cancer patient have CNS metastasis in around developed CNS metastasis in around 20 to 40% of cases. And another important point and challenge for us in today's era, despite having second generation ALK positive tumors, is development of ALK resistance, CNS metastasis, and durable control of brain metastasis. So to address these issues, a novel third generation ALK inhibitors, lorlatinib, was used in phase 3 Crown trial, and I will be discussing the data of Crown trial as well as the other available data, and I will try to highlight that to what extent the lorlatinib is able to address the unmet needs. So regarding the Crown trial, this is the study design of the Crown trial. In this study, the stage 3B or stage 4 ALK positive non-small cell lung cancer without any prior treatment were in good performance status, were randomized to receive lorlatinib in the dose of 100 milligram per meter square once daily versus crizotinib in a dose of 250 milligram twice daily in 1:1 fashion. These patient was stratified for presence of or absence of brain metastasis and the ethnicity of the patient, whether Asian population or non-Asian population. The primary endpoint of study was progression-free survival assessed by blind independent central reviewer. And this study was conducted in around 104 sites in 23 countries. The baseline characteristics were well balanced across the two groups. At interim analysis of 18 months, the primary endpoint, the PFS was not, median for PFS was not reached for lorlatinib. However, the median for crizotinib was 9.3 months. At 36-month follow-up, the benefit was consistent with the lorlatinib. The median PFS was still not reached. However, the crizotinib, the median PFS was 9.3 months. The PFS for patient with brain metastasis at baseline or without brain metastasis at baseline, the graphs, the Kaplan-Meier graph shows that the benefit was consistent in both the groups with the lorlatinib compared to crizotinib for progression-free survival. The subgroup, on the subgroup analysis, all the groups were benefited favoring lorlatinib versus crizotinib. Now, this slide represents a cross-trial comparison. However, cross-trial comparisons have their own limitation. But for primary endpoint, that was the PFS, the numerical figures was favoring crizotinib, favoring lorlatinib over brigatinib or alectinib. Now, another important point is the CNS activity, and this slide represents that time to intracranial progression, and time to intracranial progression was significantly longer with lorlatinib than with crizotinib. The patient who had brain metastasis at the baseline, in those patients, the median PFS was significantly better for lorlatinib compared to crizotinib. And the most important point is the patient who do not had brain metastasis at randomization. In those patients, the only 1 out of 112 patients developed brain metastasis subsequently. And at 38 months of follow-up, the absolute benefit of lorlatinib was around 49%. Now, this is the cross-trial comparison for brain CNS activity. And the figures again favors the use of lorlatinib over brigatinib and alectinib. Again, I will put a disclaimer that the cross-trial comparisons are not advisable. If summary of overall and intracranial response, the intention to treat population, the patient with any brain metastasis or patient with at least one measurable brain metastasis, all groups were benefited with lorlatinib compared to crizotinib. Now, another important aspect for drug is the adverse event. So, as we can see that we expect some adverse event in all the drugs. However, the drugs leading to permanent discontinuation was numerically lower in the lorlatinib compared to crizotinib. The safety profile of lorlatinib was similar to that reported in the interim analysis, and there was no new adverse event reported over a longer time, over a longer follow-up of 36 months. The major toxicities was edema, hypercholesteremia, hypertriglyceridemia, and weight gain, and peripheral neuropathy and cognitive effects. Now, in the previous speaker has talked about the CNS toxicity of lorlatinib, and I would like to highlight this point that there was no grade 4 CNS adverse event reported in the studies at the interim analysis as well as on a long-term follow-up. The incidence of CNS adverse event progressively reduces over the time. We can see that the events were more in when less than 6 months. However, on a longer follow-up, the events reduces, and predominantly events were grade 1 adverse event. So the majority of patients, approximately 59%, were managed without any intervention. CNS adverse event lead only 2 patients permanent discontinuation of treatment, and long-term analysis confirmed that CNS adverse event remain manageable over the time, and lorlatinib dose reduction did not impact the intracranial efficacy. And these patients can be managed with either dose reduction or interruption of therapy or use of concomitant medication for the adverse event. So what is the key takeaway from CROWN trial? This updated long-term data of CROWN trial confirmed the efficacy of lorlatinib over crizotinib in patients with treatment-naive, ALK-positive, non-small cell lung cancer, and support the use of lorlatinib in these patients with or without brain metastasis. No new safety signal were observed with a long-term follow-up. Now, apart from CROWN trial, there are 2 meta-analysis, network meta-analysis. So this was the first network meta-analysis. This is the design of the network meta-analysis. And for the primary endpoint, that was the PFS. And this meta-analysis compare the other available ALK inhibitor TKIs. The lorlatinib, the conclusion of this was that lorlatinib is an effective first-line treatment for ALK-positive non-small cell lung cancer when compared to crizotinib and other next-generation ALK-positive TKI, ALK inhibitor TKIs.
Sir, excellent presentations as always. A request if you can conclude in next 4-5 minutes.
Just two more slides. This is the another network systemic review and network meta-analysis. So this you can see that the forest plot favoring the lorlatinib over brigatinib and alectinib. So to conclude that the lorlatinib has significantly improved PFS than the brigatinib and alectinib. There was no significant difference found for overall survival and adverse event. Among lorlatinib, alectinib, brigatinib, and crizotinib, lorlatinib has the highest probability to reach the best novel overall confirmed response rate. And in terms of PFS, the result indicate lorlatinib was best treatment choice for patient with ALK inhibitor naive or untreated ALK positive advanced lung cancer. Another point is the lorlatinib is active against all the major ALK resistant mutations, and these are the resistance mechanism for ALK, which is for lorlatinib, which are ALK independent bypass mechanisms. So this slide summarizes all the ALK inhibitor TKI available and their PFS. Thank you.
Thank you, Pramod, for a wonderful talk, and it will be not fair to discuss lorlatinib versus alectinib without Rohit Ravelu, and it will be again a challenge. Now, I invite for the next talk Dr. Rajit Chennana. He is senior consultant in Dharamshila Narayana Hospital, Delhi. He will be talking on EGFR mutant non-small cell lung cancer, recent advances.
Thank you, Dr. Tarachan. So my topic is recent advances in treatment of EGFR positive metastatic non-small cell lung cancer. So I think we must have gone through this presentation previously also. So I'll just run through my presentation. So coming to the burden of disease, non-small cell cancer is the major histological cause of lung cancer. And lung cancer is the second most commonly diagnosed cancer, representing around 1 in 10 cancers diagnosed and around 20% of worldwide death. And EGFR mutations are observed in 40% and 20% of patients with non-small cell lung cancer in Asian and non-Asian populations respectively. And in Indian patients, the data is around 20 to 23%. So there are three generations. First generation, that is erlotinib, gefitinib, which reversibly binds to the wild type and mutant EGFR. Second is the afatinib or dacomatinib. And third generation is osimertinib, which we'll be discussing in our subsequent slides. So first generation, we know that gefitinib was the first drug that was approved, and followed by erlotinib. And then second generation, we have afatinib on the basis of Lux Lung 7 and Archer 1050, dacomatinib. The overall survival of dacomatinib was 34.1 month, and the PFS was 14.7 month. And third generation osimertinib, the OS was 38.6 months, and PFS was 18.9 months. So the second generation and third generation, they do much better than the first generation. So what is the best option for giving, what is the best TKI to be used? So what all parameters generally do we see while deciding the treatment? Longer PFS, higher response rate, better overall survival, reduced CNS mets, good safety profile, improved quality of life, and prolonged time to first subsequent therapy. So in terms of PFS, afatinib PFS is around 11 months, gefitinib is around 10 months. In Archer 1050, dacomatinib is 14.7 months, and Flora showed that the PFS with osimertinib was 18.9 months with a hazard ratio of 0.46. So osimertinib has the highest median PFS, and there is early separation of PFS curves. And the early separation also indicates a lower frequency of early resistance to osimertinib. Coming to the mutation subgroup also, osimertinib do fairly well as compared to other TKI. In exon 19, the mutation, it is 21.4 month, and with L858R, it is 14.4 month. So osimertinib demonstrates the longest PFS regardless of the mutation type. So we have checked the first point, that is longer PFS. In terms of objective response rate, you can see that the overall response rate with osimertinib is around 80%, afatinib around 70%, dacomatinib around 75%. So it's more or less similar. Osimertinib has slightly better overall response rate. In terms of overall survival, whatever data we have, there is no head-to-head comparison. So osimertinib, the OS is around 38.6 months in the Flora study. In the Archer 1050, dacomatinib, it is 34.1 months. So in the Archer 1050, OS was not statistically significant, but because the trial was not designed to calculate the OS, we will skip this slide. So in terms of OS and response rate also, osimertinib fares better than other TKI. In terms of CNS activity, we know that osimertinib is probably one of the best of the TKI we have. The median PFS in those patients with CNS mets was 15.2 months versus 9.6 months. And in Archer 1050, the CNS mets patient, they were not included. Osimertinib demonstrated a superior systemic PFS regardless of the CNS disease at baseline. So reduced CNS mets, osimertinib is also checked. Regarding the safety profile, we all know that osimertinib is a very safe drug. Hardly any patient developed grade 3 or more side effect. Diarrhea, decreased appetite can happen in few of the patients, but most of the side effects are manageable. With dacomatinib, there are chances of diarrhea and skin rash, which can happen in around 60% of the patients. So in terms of side effects also, osimertinib fares better as compared to dacomatinib and afatinib. In terms of quality of life also, the global quality of life in the Flora trial was improved from baseline in both osimertinib and EGFR TKI treatment arm. So the quality of life is maintained, and it's in fact improved. And in terms of first subsequent therapy received, you can see that osimertinib in the second line, around 48% of the patients received next line treatment, and the majority of the treatment was cytotoxic chemotherapy that was received in 70% of the patients. In the comparator arm of the FLORA study, 65% patients received the second-line treatment. Majority was TKI of cytotoxic chemotherapy. So the time to first and second subsequent therapy in FLORA study was 25.5 months and 31.1 months respectively. So is sequencing the right strategy? So basically my take is that it basically depends on the profile of the patient and the affordability of the patient. So amongst all the TKI we have, if the patient can afford, osimertinib is possibly the best TKI even in uncommon mutations. And if the patient is having difficulty to take osimertinib in first line, then the second generation TKI should be the standard, and maybe in second line we can offer osimertinib. If the patient has T790M mutation or whatever the on target or off target mutation the patient develops. So the first line treatment should be the one of the best possible treatment that we should offer to our patients, because only around 30% of the patients treated with first or a second generation TKI, they are able to receive second line osimertinib, because of the incidence of T79 mutation is probably less than 50%. So is there a best option? So it depends on the clinical scenario and patient to patient. If affordability is not an issue, then osimertinib is the standard treatment for both common and uncommon mutation. In uncommon mutation, probably we'll get the update of FLORA2. Maybe we can add chemotherapy. So osimertinib is recommended as the first line treatment option for common mutations, EGFR exon 19 and exon 21 L858R, along with second generation TKI like dacomatinib, afatinib, and first generation TKI. So we have real world studies which have also demonstrated that osimertinib has shown better outcomes as compared to comparator arm. So NCCN recommends all the 5 TKI as first line treatment option, along with erlotinib plus ramucirumab, erlotinib plus bevacizumab as category 1. So it is osimertinib is the only TKI which has demonstrated a clinically and statistically significant improvement in overall survival. So with this, I would like to conclude my presentation, and I would like to thank the organizers.
Thank you, Rajit. Now I invite for the next topic, Dr. Vikas Talreja, for advances in the treatment of MET exon 14 mutation in non-small cell lung cancer. Dr. Vikas, over to you.
Very good evening and welcome back again, everybody. And I really thank Dr. Tarachan once again for inviting me. And I hope it's a 9:30. Half of you might be asleep, won't want to bother you furthermore. But we'll be quickly finishing off a very important topic. May I request the slide sets to be shared on behalf of me. MET exon 14 is something which is very, very important and has changed the way we manage the treatment right now.
And can we have the slides, please? Yeah, Kirtik. Great. Over to you, sir.
So even though it's a rare mutation, it must be tested as with the other mutations. And as we test more and more of it, more it will become important with the increase in incidence of it. Next slide, please. And that has been the lung paradigm shift as we see. We have discussed a lot, and MET has been an important component. 3% of the total testing of the oncogenic driver mutations is MET mutations. Next slide, please. And we have agreed across all guidelines that across NCCN and the European guidelines that MET exon 14 skipping mutation must be tested via tissue or liquid biopsy in all patients who have an advanced non-small cell lung cancers, and they the methods can be the NGS method, the PCR, the IHC, or the FISH, but any method prove it an important method to be tested. Next slide, please. And why it is important, because as is the standard of all EGFR ALK driver mutation negative patients, we give chemotherapies, but with MET, I believe it's something MET inhibitors do play a very important role, with a median overall survival nearly tripling with the MET inhibitors. Next slide. As you could see with the hazard ratio we were discussing with ADAURA, the MET inhibitors have an hazard ratio of 0.11, meaning a 90% reduced chances of disease progression or increase in the life, as you could see, with a median overall survival reaching up to 26 months with met exon 14 skipping mutation inhibitors as compared to giving chemotherapy or giving immunotherapy. As you could see, immunotherapy also provides a very limited benefit with the met exon 14 skipping mutations. Next slide, please. And that's where it has been unanimously agreed that be it Europe or be it US, the first line is the tepotinib or the capmatinib being the selective MET exon 14 skipping inhibitors. Next slide, please. Crizotinib now has its efficacy, but yes, they are uh, something which we need to reserve. So there are three types of MET inhibitors, all different in their efficacy and selectivity. We have the type 1 inhibitors, which are basically the ATP competitive bound, and they specifically bind to the activation loop of the MET with a U-shaped conformations. So uh, tepotinib and capmatinib and savolitinib are those MET specific, while crizotinib has other targets also. The type 2 inhibitors are those which have a competitive binding, and they have the potency depends upon the activation site of the MET protein, and therefore the off-target effects are quite there, as you can see with cabozantinib, meratinib, and the glisatinib. And the third one is the non-competitive ATP binder, that is the type 3 inhibitors, tivatentinib, which is not MET specific. Next slide, please. Next slide, please. And that's where we'll discuss the vision study. A very simple study, single arm phase 2 of tepotinib, where all metastatic advanced non-small cell lung cancers with no prior treatments were given, or treatments less than 2 lines of therapies were given, tepotinib 450 milligram once daily. And they were stratified whether they had been treatment naive or previously treated, and baseline characteristics were exactly matched with each other. The primary endpoint being the overall response rate, the secondary endpoint being the duration of response, the overall survival. Next slide, please. Look at the median PFS, that's 15.3 months with oral tepotinib being given once daily, and the median overall survival reaching up 26 months. The waterfall plot and the Summers plot always showing a consistent benefit of sensitivity. So those were the responses that you could see. 60% of them responding, and the duration of response was quite long, as you could see, 46.4 months, nearly 5 years of response, and you could see the disease control rate was 83.8% with the MET inhibitors in treatment naive patients. Next slide, please. And those who were pre-treated, the duration of response was 10.2 months, the median progression-free survival was 11.5 months, and the median overall survival was 20.4 months. Again, an impressive response rates, duration of response, the overall survival with them. And these were those patients who were previously treated. So comparison between the two, a food for thought, that the earlier we use, the better it is, and the better, the longer the patient lives for the same. Next slide, please. If you look at the patients who had a brain metastasis with the MET exon 14 skipping mutations, 88.4% had some intracranial disease control, 66.7% had an intracranial response, and 20.9 months was the intracranial progression-free survival, and the duration of response was not achieved, meaning those who kept on responding had a beautiful response, as you could see from the various classical examples, as you could see in those pictorial diagrams, and the response rate curves with the swimmer plots again showing a beautiful response throughout. Next slide, please. And you could see that not only the Western benefit, the Asian patients also with the treatment naive also had a similar overall response rate in the first line with 66%, with the duration of response not achieved, median progression-free survival 15 months, and the median overall survival not achieved. Next slide, please. Similarly, if we use in the second line Asian patients also, it was uh, reciprocal with the clinical world data. As you could see, the response rate 50%, duration of response 10.8 months, median progression-free survival 12 months, and overall survival of 20 months. Next slide, please. And with the current therapeutic armamentarium we have right now, tepotinib provides us a robust data as you compared with the capmatinib and the savolitinib. If we look at, we have the treatment naive data, we have the treatment progress data, first line, second line data, also the tissue data and the liquid based data. and also a very simple dose that is 450 milligram once daily, as compared to capmatinib, which is 800 milligram twice daily schedule, meaning a 4 tablets the patient has to take. And if we look at the brain penetration, 25% of them do have a brain penetration, as compared to capmatinib, only 9% of them have it. And look at the potency of it. So again, 1.7 is not a bad number to have it. 86.6% intracranial disease control, 71.4% intracranial control. Very good data to look forward to. Next, please. And adverse events being the edema, nausea, slight creatinine increase, AST, ALT increase, hypoalbuminemia. So 14.7% had discontinuations, while with capmatinib it was 16 plus patients. Next slide, please. And edema is we see is a frequent class effect of the patients with MET inhibitors, most frequently seen with it. And it's because probably the inhibition of MET is also in the vascular and lymphatic endothelial tissue, causing it to cause the peripheral edema. And MET inhibitors may not be immediately symptomatic edema, and time to onset may differ between 8 weeks to 5 months. Next slide, please. So the risk also increases with patient's age, and also it is sometimes independent of as what time and how much long is the MET has been given. Always important to use diuretics with under the supervision of the medical oncologist to deal with. And tapentadine, as we know, if once develop a side effects, you can easily reduce the dose to 250 milligram, and always be very careful with especially grade 3, grade 4 side effects of diarrhea and hypoalbuminemia. Next slide, please. Next slide. MET has also been a very important resistant mechanism post first-line FLORA data. As you could see, 30% of them do have a MET amplification, and in the INSIGHT-2 study, you could see 30% of them did have a MET amplification post osimertinib exposure. Next slide. And that's where the very important is the combination of osimertinib plus tepotinib at the INSIGHT-2 data, that all patients who had an EGFR mutation started with osimertinib progressed, were added tepotinib 500 milligram once daily, as compared to giving only tepotinib monotherapy in a phase 2 study fashion, with the primary objective of an overall response rate. Next slide, please. Next slide, please. So you could look at those responses. It's brilliant responses, 55% in those patients with osimertinib plus tepotinib combination, and you could see the duration of responses also with more than 9 months of the follow-up consistently with it. Next slide, please. These are the swimmers plot, and you could see most of them do tend to have some kind of responses in terms of the tumor shrinkage. Many of them do have a complete response also. Next slide, please.
Sir, request if you can summarize your discussion, please.
Please go to the last slide. So safety profile, we already know. Conclusion, yes. So the tepotinib plus osimertinib does show good potential mechanism to add upon post-osimertinib failure and the first-line MET exon 14 skipping mutations. The data of the VISION trial is exemplary. So tepotinib does play a very important role in not only MET exon 14 upfront, but also in the MET amplification in the second line, and definitely should be considered for our patients. Thank you for the opportunity. Thank you, Mark, for the session, and I thank wholeheartedly Dr. Tarachand for inviting me for the talk.
Thanks, Vikas, for your wonderful talk. Now, I would like to thank our all the esteemed speakers and faculties, from starting from the senior most Dr. Naresh Somani and Dr. Charuvel, who is a molecular pathologist, highlighted all the molecular importance in the non-small cell lung cancer. And then the special thanks to Dr. Vikas Talreja, who on a special request came as like a Sankat Mojak at that time for the panel discussion, and a wonderful talk in the last. So starting and ending with the Dr. Vikas Talreja. And after that, I would like to thank Dr. Tanvi Sood, Dr. Pramod, Dr. Akhil Kapoor is moderated on the nicely moderated uncommon non-mutations, and Dr. Rajit Chanana, and Dr. Rohit Rovelo, and other our esteemed panelists, Rohit Swami, and Dr. Preeti, Dr. Lalit Sharma, Dr. Jitendra Pelajani, Dr. B.S. Nehra, and other panelists also. So now in the end, I would like to thank also our academic partners, BMS, AstraZeneca, Merck, Lupin Oncology, Fresenius Kavi, Cipla Oncology, Dr. Reddy, Midgenium, and Viatris, Roche, Pfizer, Orient, and Zydus. And also, I would like to thank Horizon team for smoothly conducting this webinar of today only. And I hope to meet all of you tomorrow for the next topic, head and neck cancer, as a burning topic in India and also most important Rajasthan also. Thank you all.
So thank you, Dr. Tarachan sir, for these kind words. On behalf of my colleagues, Mahima and Kitika, thank you so much for giving this opportunity. Good night, everyone. Stay safe, stay blessed. We see you tomorrow at the same time, 7 p.m. Please do not forget